and then we'll resume our workshops by the second workshop about asthma workshops, and we meant to make it this year as case scenarios. And the last workshop, which will be advances in non-invasive ventilation, chaired by our colleague, Dr. Khalid Al-Awam. And the first workshop is going to be chaired by our colleague, Dr. Isa Al-Rashidi. Dr. Isa Al-Rashidi is a pediatric pulmonologist from King Saud Medical City. And also he was going to introduce our first guest speaker, who's going to deliver the first workshop. I take this opportunity to special thanks to Dr. Said Ben Nihaya for his kind acceptance to take care of this workshop. Just today, we invited him. Our previous speaker apologized for the last minute. So Dr. Said, it's really our great appreciation and thanks goes to you. Dr. Said, Dr. Rashidi, if you are there, please, you can take over and introduce your speaker, and wish you all very successful workshops. And inshallah, we'll continue our program tomorrow starting from 1 p.m. and Saturday it will be early morning, 9:30 a.m. Dr. Isa, the mic is yours, and good luck.
Assalamu alaikum. I would like to thank Prof. Adil for his really hard work to try with his colleague to make it very easy, and he really bring the most expert guys to talk about something very, very important in daily round we do it. I will organize this workshop with Dr. Saeed, and he will talk about around 1 hour about workshop about pediatric radiology. Dr. Saeed, he is a consultant pediatric radiology and intervention radiologist. He's working since 2014 as a consultant interventionist in Prince Sultan Military Hospital. He had double fellowship in pediatric radiology, and he's the program director. It's really amazing. I'm sure it will be amazing topic about the important topic in pediatric radiology. Dr. Saeed, you are so welcome. I'm really interested in listening with all the talk about it, and I appreciate your support. Dr. Saeed, the mic is yours.
Thank you all. Do you hear me, Dr. Isa?
Yeah, very clear.
Yeah, thank you all. It's my pleasure to be with you in this very excellent conference. So just there is no time, so I'm just we'll start now.
Yes, I will remind you after half of the time, just to prepare. You have 1 hour.
Okay, thank you. Sorry for this, just 1 minute. Do you still hear me? Hello?
Yes.
Is it shared now, the screen, or not?
Now I don't see it still.
Just see now. It's shared now, I think so.
Yes, it's yeah, I think now we can start, but we don't see the presentation yet.
Just a minute, please.
Okay.
Is it shared now?
Till now, I don't see things.
It will be fine. Is it clear now?
Yeah, you can start now. I think it's clear.
Sorry for this. So, dear all, it's my pleasure to be, as I said before, with you, and this is excellent conference. So I have two talks. The first talk will be about the basic of interpretation of the chest X-ray of pediatric. The second talk will be about chest intervention in pediatric patients. So, as we know, the chest X-ray is the most commonly requested radiological imaging in practice, not only for pediatric, but for all patients. So most of the, and we just go to the most indications of the chest X-ray in pediatric patients or for pediatric patients. The most important is one of the most important reason or justification is the respiratory distress, especially in ICU patient, cardiac disease, bronchiolitis, pneumonia or infection in general, pulmonary tuberculosis and pneumothorax and trauma. Also for screening for foreign bodies on as a part of the septic screen, and also confirmation of the location of the tubes and lines. So as a basic or the first role in the interpretation of chest X-ray, you have to make sure that this examination is good. I mean, the quality of this exam is good. And as we know, we have different views or different projection. And the most requested exam in the pediatric patient is the AB. And because most of the pediatric patients are sick patients, and also the age is make difference, because like if the baby is like less than 2 years, he's not able to stand. Though there is some, I mean, there is some machines which can't help to get a BA projection of posterior anterior views. But the most common requested exam is AB. And not AB erect, but supine, as we said, most of the patients are sick patients. There is an alternative projection like lateral or cross-table lateral, and this is not the commonly requested. So as we said, the basic of chest X-ray interpretation is the most important is to check about the quality of this view. And there is, you can just remember three three things: is rotation, inspiration, and penetration. Rotation, that the patient is centralized. There is no rotation or tilting of the patient. And inspiration, that means there is a good lungs volume. And this can be done. We just check it in the next slide by counting the ribs anterior or posteriorly, and make sure that the patient take good inspiration. It's very difficult to control this in pediatric patient, but still you can just modify your examination or your shot according to the cycle of the respiration of the patient. So it's make difference in diagnosis and interpretation. Sometimes it gives you false negative result or finding if the patient didn't take a good inspiration or deep inspiration. Penetration, and this is also to make sure that the factors or X-ray radiation factor is appropriate for the patient, and this can be solved now with the back system. You can control the penetration and if it's bright or too dark, and this can be controlled easy by in the back system. So let's start with this is an example. Before that, there is a steps, which is I prefer this and doing in my practice, and also I taught my resident and fellows. So if you follow these rules or these steps, it's like 90%, 95%, you will not forget anything. Okay. So first of all, we just say the quality of image, make sure that the quality of the image is good. The second thing is checking for the artificial things like tubes and lines. Make sure it's an appropriate position, and you have to be familiar with such things so you can differentiate between the central lines, Beck's lines, or umbilical lines, and also between all types of tubes like chest tubes, gastric tube, or nasogastric tubes, or nasojejunal tubes, and make sure that every tubes or lines in the appropriate positions. Then after that, we can start. What I usually do is starting from central and going to the peripheral, and you can start from the abnormality, and then you have to check all this. So sometimes, like if you are in hurry, you just see the abnormality, and you can check all this later on. So then cardiomyopathy size outline, make sure that there is no cardiomegaly, and also is not the size only. The outline is very important. Okay. Then go to the pulmonary vascularity, make sure that there is a normal pulmonary vascularity and there is no increased pulmonary vascularity or decreased pulmonary vascularity. Then after that, you go to the lungs fields and check it if there is abnormal obesities or abnormal lucences or any nodules or pulmonary nodules. After that, you can go to the pleural spaces, check the pleural spaces, and make sure there's no pneumothorax pleural effusion. This is the most common things, or any added obesities and or pleural-based obesities or masses. Then go to the soft tissue and bones and make sure that check the hidden or the corners of the image. And this is very important. Most of the people just check the lungs and the central part of the image, but they are not check very well the corners or the hidden areas in chest X-ray. And this is very important. Then one of the important things you have to check it is the previous examination. Most of the times you can check, you can know the diagnosis by checking the previous examination. So if anything, just if the previous X-ray is normal and you have abnormality now, so it will make your differential diagnosis is very short. Next, see, this is image. So this is chest X-ray. Frontal view most of the time, most likely is AB view. So we go to the lines and tubes. I cannot see any lines and tubes. Before that, you check the quality of the image. You see there is a good lungs volume. That means there is a good inspiration. And also the patient is centralized. There is some tilt. You see that there is a difference between the medial ends of the clavicles. It's not, you see, if you check the distance between the medial part of the medial end of the left clavicle is not equal to that between the right clavicle and the midline and the spinous process of the vertebra. This is how to check one. This is a one way how to check for the patient is centralized. Patient is not tilted, and as we said, this is a good respiratory effort. If you can check, you see, you can check the anterior ribs, counting the anterior ribs. At least you need to have at least 5 or 6 ribs anteriorly or anterior ribs posteriorly. See, this is the, you see, and this is the posterior ribs. 1, 2, 3, 4, 5, 6, 7, 9, and this is the 10th posteriorly. And if you want to check the anterior ribs, this is 1, 2, 3, 4, and 5, and 6. So there is a good inspiratory effort here. Then the penetration, you see the quality of image is excellent. How to check this? You need to see, you need to see some of the spine through the lungs, and that means that there is a good penetration. This is another example. You see, and this is another chest X-ray. So what we have to check the quality of the image. The first thing, there is the patient is not, I mean, centralized. There is some tilt, you see. So there is some tilt to the left side. And regarding the inspiration or the volume of the lungs, it's acceptable. You see 1, 2, 3, 4, 5, 6 anterior. That means there is a good inspiratory effort. Okay, penetration is good, and again you can see the spine through the heart and lungs. Okay, now we go to the tubes and lines. As we said, what is this? This is a big line because it's going from the arm. You can trace the tubes and line to recognize it very well. Okay, and what's the appropriate position of the big lines? We usually we check about the right main bronchus. This is the landmark in chest X-ray. Is a cross landmark in the frontal chest X-ray to check the appropriate or the proper position of the central or big lines. The ideal thing is the tip should be just below the lower margin of the right main bronchus here. This is the position, or this is the region or the area of the right atrium SVC junction, which is the ideal position of any central or peripheral lines or the big lines for the pediatric patient, because you don't want to have it very long in the right atrium. This might cause, most of the time, cause arrhythmias, and also you don't want it to be short, with gonna flip like this, because this line is short, so it's flipped. And where is it now? This is brachial vein, axillary vein, subclavian vein, joined to the junction between anterior jugular vein to the SVC and crossing the midline to the other side. That means it's in the left brachiocephalic or innominate vein. Still, you can accept that, but if you like, it's better to change it. If the line, or if you need a long-term IV access, like if you need it for more than 1 week or 2 weeks. But if you need it just for 2 days or extra 3 days, you don't need to expose the patient to another GA and invasive procedures. Okay. Now, as we said before, what's the next step after that? Tube and lines. You check about the cardiomediastinal size, and this is the mediastinum, and this is the outline of the cardiomediastinal size. And this is how to check for the size, okay? You need to cross estimate of this dimensions. Ideally, it should be less than 50% of this, equal or less than 50% of this diameter. This is the lung diameter, the maximum lung diameter. But in the patient less than 1 year, it up to 60% is still acceptable, okay? So more than 1 year old, it has to be less than or equal to 50% of this diameter. Then the outline, it has to be smooth outline. There is no bulge. What is this attenuation? This is the normal thymus tissue to have. So you need to know the normal thymus tissue attenuation and what's the age of the, you can see the thymus tissue, okay? I cannot go through this because the time limit. So then after that, so this is a acceptable cardiomediastinal size. Still there is like borderline heart size, but it's acceptable, okay? After that, you go to the pulmonary vascularity, okay? What is this? Some of the people, they said this is a pulmonary reduce. How to differentiate? This is not a pulmonary reduce. The pulmonary reduce most of the time or always is distributed randomly, okay? So it's not taking this orientation, okay? Or this is arrangement, okay? This is a vessels, okay? This is a pulmonary vascularity. But if it's pulmonary nodule, I will show you some example of one example of pulmonary nodules. You can see there is another one. If it's pulmonary nodule, you will see one hair, one hair, one hair, one hair, one hair, and another maybe one hair, okay? But this is take like it's arranged, I mean, in like similar arrangement in both sides. So this is a pulmonary vessels. That means, so how can you say this is a normal or increase or decrease? You have, if you want to see something is this is a large or a decrease or this is a small, you have to have a reference for that. So what's your reference is the adjacent bronchioles. Maybe it's very not obvious for you, but you see this is the black dots here or lucency. This is the adjacent bronchiole of this vessels, and you see there's a it's more or larger than the adjacent bronchioles. If it's equal, this is a normal. If it's significantly decreased, that means there is oligemia or decreased pulmonary nodules. So what does it mean, increased pulmonary nodules? Increased pulmonary vascularity, it means left to right shunting, okay? And this is most of the time in the case of congenital heart disease. What's the differential diagnosis? It's a long list, and it depends on the clinical scenario of the patient and the age of the patient. If the patient is cyanotic, it gives you, so you can ask, and you know the patient is cyanotic or not cyanotic. If the patient cyanotic and there is increased pulmonary vascularity, we can see the 5 T's, okay? Truncus arteriosus, transposition of the great vessels, tingle ventricle. It's just they said tingle because but it's a single ventricle, but to make it a 5 T's, okay? And also we said the transposition and also total anomalous of pulmonary venous return, okay? If the patient is not cyanotic, you can remember 3 letters disease, BDA, okay, and ventricle septal decay, VSD and ESD, okay? You can remember this. I cannot throw all this pulmonary or the congenital heart disease example of which can increase pulmonary vascularity, but this is an example. So then after the pulmonary vascularity, you check about the lung fields. We see most of the lungs here is clear. There is some like interstitial thickening or like ill-defined infiltrate. And most of this, in such cases, most of the time is related to the increased pulmonary vascularity, is related to the increased pulmonary congestion. And we see sometimes, you can see it in our report, there is a peribronchial interstitial wall thickening, which is not specific, because it's not specific. There's many reasons can cause interstitial thickening, like increased pulmonary vascularity, congestion. It could be edema, it could be infection, it could be inflammatory airway disease like asthma or bronchiolitis. It could be early infection. Even upper respiratory tract infection can cause this finding. Then after that, you check about the pulmonary or lung field. What we mean by lung field, this is the lung field. Even this is part of the lung field, but it's obscured or overlapped by the heart. And this is also, this is the lung field, okay? Check about the abnormal obesity or abnormal lucency. Then after that, you check about the soft tissue and bones, okay? And the hidden areas, don't forget the hidden areas, okay? The upper abdomen is you have to check it, is a part of the proper chest X-ray. If there is a significant gastric distension, which might cause even respiratory distress, okay? So the solution is just ask the physician or the referring physician to insert a nasogastric tube. And we can check, maybe there is abnormal mass like lesion here or abnormal lucencies. So the upper abdomen is part of the chest X-ray. Go to the next slide. This is an example of, as we said, there is no tubes aligned. The quality of the image is excellent. I need to go like a little bit fast to save time. So no tube lines, quality of images is excellent. Pulmonary vascularity is clear, okay, or normal. Go to the lung field, there is abnormal obesity here, okay? It's at the apex or the right upper lobe or right upper hemithorax. So what's the differential diagnosis? Differential diagnosis is very wide, and it's according to the clinical scenario of the patient. If the patient is febrile, okay, and there is he has a cough, and the previous X-ray was normal. This is mostly right upper lobe collapse consolidation, okay, pneumonia, okay, and this is the case, and you see there is lifting of the minor fissure of the right lung, and this is an example of right upper lobe collapse consolidation or pneumonia. We think we forget about to explain about one of the most important role is the pleural space. You can check the pleural space here is clear. There is no pneumothorax, there is no pleural effusion or abnormal pleural based mass lesion, okay? You see the both hemidiaphragm are clear, okay? So this is an example of right upper lobe collapse consolidation. So this is an example of pleural based disorder or abnormality. Now we start from the beginning. What's about the quality of the image? The patient tilted to the right side, okay? I cannot see tubes and lines. Lungs volume or the inspiration is acceptable, and also the penetration is acceptable, and there is no tubes and lines. Lungs field is clear here. Now what I can see, there is a capillary lesion with air fluid levels projecting over the right main hemithorax. So the differential could be intrapulmonary or extrapulmonary. How to differentiate? If it's intrapulmonary, most likely we are dealing with abscess. If it's extrapulmonary, that means it is a pleural effusion. How can you differentiate between that? You can ask for the lateral view. You see in the lateral view, the diameter of the air fluid level is larger in the lateral, or it's large in the lateral view if you compare it to the frontal view. That means this is a pleural fluid. This is a pleural effusion, not a pulmonary abscess. If it's a pulmonary abscess, you will see the level. This is the diameter of the air fluid level. It has the same diameter or dimension in both views, lateral and AB view or frontal view. Okay. So what's the next step of this? It's very clear. You can go and ask the interventionist or the radiology to put a chest tube. And if you want to make sure about the volume and these things, you can check for ultrasound. Okay. This is an example of, let's start from the beginning, please. So what's about the rotation? The patient, there is a little bit tilt to the left side, which not affect actually the images. Okay, penetration is acceptable. You see you can see the spines here and the vertebrae, and also the lung volume is acceptable also. 1, 2, 3, 4, 5, 6 anteriorly, left seen. Then you go to the pulmonary vascular. There is no tubes and lines, and the lung fields here is the pulmonary vascularity is acceptable or normal, and the lung fields is on the right side is clear. The lung is clear here. There is part of just minimal interstitial, peribronchial interstitial thickening, which is not specific, as we said. And this is, you can see before that, your cardiomediastinal size. Sorry, we forget, this is the most important things. The cardiomediastinal size, you cannot clearly demarcate the whole outline of the cardiac. Okay, there is overlapped or added density here. Okay, so what's the differential diagnosis? Also, the left hemidiaphragm is clear, so there is added density or obesity in the left hemithorax, which obliterating the adjacent cardiac border and also obliterating the left hemidiaphragm. So what's the next? If the patient if he has a normal chest X-ray, like after 1 or 2 weeks, that's most likely you are dealing with lung problem and it's like infection. But if there is no previous examination, we need to ask for a cross-sectional image, okay? And this is the next step, you see? So you see there is a different density mass lesion, anterior mediastinal mass lesion with different density, okay? The soft tissue and the fluid density also. So this is a case of teratoma, okay? This is a case of teratoma. So the CT confirming that it is extrapulmonary, it's not a lung problem. It's a mediastinal disease or mass lesion with different attenuation or different density and turned to be mature teratoma. So this is the last example, I think, for the chest X-ray interpretation. Okay, we can see that checking the centralization or the position of the patient. There is a little bit, the patient is not tilted, but there is a mild scoliosis here, which is acceptable, okay? The lungs volume is acceptable also, 1, 2, 3, 4, 5 anteriorly, up to 6 ribs anteriorly. This is acceptable or good inspiratory effort. And also the penetration, you can see part of the vertebrae through the lungs and the heart, and this is excellent penetration. Tubes and lines, what is this? You see, if you see this line, you see it's coiled here, okay? And the tip, as we said, it's on the just below the lower margin of the right main bronchus. This is a proper position of these lines. Okay, so what is this? Is this just permanent cath, or just a quintal line, or back line? Definitely it's not back line. You see the no tubes in the arm. It's not central or quintal line because there is no, you see this is the curve of the line. It's in the chest. So either this is a perm cath or porta cath. And it's a porta cath because this is the access needle. You see the access needle is here. Already the port is accessed. If you see this coil in this, you see it's kinked here, or it's not kinked, it's coiled. And this is a porta cath done by the pediatric surgeon because they cut down subclavian vein and they push the catheter, but it's completely different from what we are doing. We are doing the pediatric intervention, they access the mainly the right internal jugular vein or the left, and the curve of the catheter will be nice curve like this. Okay.
Doctor, you have 30 minutes, huh?
Okay, no problem. Okay, so and so we have a porta cath in proper position. Now, what's the process abnormality here? The pulmonary vascularity is normal, okay, and there is abnormal rounded density, okay, and it's scattered, okay, scattered randomly distributed in the lung. This is one, and this is the difference of, and this is one, and this is another one. I don't know if it's clear for you guys or not. So 1, 2, 3, 4, 5. So this is a rounded, multiple rounded masses or pulmonary nodules, okay? So they're completely different, or you can completely discriminate or differentiate this from the pulmonary increased pulmonary vascularity, okay? So this is a multiple pulmonary nodules, okay? We finish from the lung, okay? Going to the where? To the pleural space. You see? There is like increase or thickening of pleura. And this is also another opacity, not separable from the right pleura. So this is a pleural-based mass with layering pleural fusion, okay? And this is very important. In the adult, you can see the most important signs in the adult or BAFU is obliteration of the costophrenic angle, okay? But in pediatric, most of the patients are sick, like this patient, and the pleural fluid will layering, okay? It's like if you have a water in a cup or in the bottle and you just flip it or just tilt it, okay? So this is the most important things. If you see a pleural thickening here, this is indication of a pleural fusion. And you have to, if you need to confirm it, you can ask for ultrasound. So what's the important things here? Anybody can see anything very important here? Okay, we see we have soft tissue and bones, okay? And as I said before, don't forget the heading or the corners of the image. You see, the left shoulder is missed, okay? And this is the key of this image, okay? This is a patient, unfortunate patient, presented late with the Ewing sarcoma of the left arm, okay? I did for him embolization of the subclavian axillary artery just before the resection of the left upper extremity. And this is the pulmonary metastasis, okay? And also there is a pleural metastasis and also pleural fusion. And another key that's this patient is oncology patient is the porta cath. Okay, I think we're done with the first lecture or the first talk about chest X-ray interpretation. So we go to the next. Dr. Isa is still, do you see the image or not yet, the PowerPoint?
Yeah, just I think I will wait till the presentation. It was really a great talk. I think we'll see the next one. I'm so excited to see it. Thank you very much. I will
just
wait
give me
for
a
the
second.
second one.
Will appear in the next talk.
Sure.
It's okay now?
Okay. Yeah, clear. Go ahead.
Okay. So the next talk will be chest intervention in children overview. I'll just speak about some of the most common procedure requested in children. So for that, I need to go for a little bit fast because there is too many slides. The pediatric intervention radiology, it's a range of minimally invasive procedure which are performed using image guidance procedure, and maybe it could be for diagnostic or therapeutic purposes. The scope of for image guided intervention in the chest is very wide, which can include the procedure in the heart, pulmonary and systemic vasculature, lungs and pleural cavities, airways, and esophagus also. This review describes the most common procedure or requested procedure. This is an example. What is this? This is, as we said, this is a portica. And you can see this is, if you trace, the catheter is missed here. So it's a broken, and it's the distal end projecting over the left hilum, most likely on the left pulmonary veins. Okay, so this is an example of a procedure, a chest procedure in pediatric, portacath insertion or central line insertion or permanent catheter insertion. Okay, this is an example. So this is an example of the venous access in pediatric. As we said, I have to go fast.
I think, Doctor, you have more extra 10 minutes.
No problem. Okay. Excellent. Going to the most common, one of the most common requested procedure in pediatric is the chest tubes, and chest tube either for pneumothorax or pleural fusion. And we start with the pneumothorax. As you said, pneumothorax is referred to the presence of gas or air in the pleural cavity. The spontaneous or secondary to a wide variety of etiology. The most common is the infection like pneumonia. Another most common cause of this is bronchopleural fistula, chest trauma, and atherogenic. Tension pneumothorax is referred to the progressive accumulation of air under the pressure in the pleural space, resulting in serious cardiopulmonary compromise. Regardless of the etiology, asymptomatic pneumothorax can be effectively drained with a chest tube. Okay, so what's the most indication is the symptomatic, if the patient is symptomatic, regardless of the size of the pneumothorax. And this is an example of, you see, this is a pneumothorax. You can see the pleural wall here, and this is the part of the during the procedure. You just access the pleural cavity under fluoroscopy or even under the ultrasound guidance. Inserted the bushing or advance a guide wire. Then this is the after insertion of the pigtail catheter. And this is a follow-up after clearance of the previously seen left side pneumothorax. Pleural effusion. A pleural effusion refers to presence of fluid collection in the pleural spaces. Pneumonia in children can be complicated by pleural effusion, emphysema, and abscesses. Image-guided technique are followable and non-operative alternative with a high success and low complication. Is less invasive when compared to the chest tube done surgically or without image guidance. According to the content of the pleural or the fluid, the pleural effusion, we can classify the effusion. It could be hydrothorax, hemothorax, chylothorax, emphysema, or malignant pleural effusion. Chest X-ray can be suggest an effusion, as we said before, and you have to considering that the patient all are X-rayed or the imaging was of the chest X-ray most of the time taken in a supine position because most of the patients are sick patients, as we said. So you have to check about laryngeal pleural effusion, not absence of the costophrenic angle. The ultrasound is the golden or the tool to confirm the presence of the pleural effusion. CT is not, is not recommended because the radiation. But sometimes if it's very difficult to see it, or if you want to clarify what's the cause of the reason, the pleural effusion, you can ask for a CT. Drainage indication includes significant pleural effusion, like 1 centimeter width, but the golden rule if the patient symptomatic. If the patient not symptomatic, just forget it, okay? We can grade it up to like a small, moderate, or large effusion, but even if you see it in the chest X-ray or pleural on the ultrasound, you consider it as a small or moderate, but the patient is symptomatic, so you have to interfere and put a chest tube. And you have to select the proper chest tube. Don't go or underestimate the pleural effusion. Go to the highest caliber of the chest tube, which can increase the output. And also, if the effusion is a little bit turbid, it can be easily drained. This is another example, or this is an example of pleural. You see? You can see still the costophrenic angle is clear here still, but like there is a loculated or we can say this is a basal, and if you want to interpret it, this is a chest X-ray. This is a left pleural based obesity, left pleural based obesity. Differentiant could be mass, it could be effusion. So what's the next step is the ultrasound, confirming the presence of effusion. This is the black one here, and this is the septi, okay? And this is during the procedure. This is insertion of the, and confirming that you are in the pleural effusion. This is a needle during the procedure. Then you can push the guide wire and put advance the catheter. This is another example. You see, this is the larynx, you see? It's not like that before. You see, this is a larynx pleural effusion bilateral, and this is during the procedure. This is the needle or the guide wire, and this is after bilateral chest tube insertions, okay? This is a real scenario. This is a 2-year-old female with fever. This is what we said before. So as we said before, after ultrasound or lateral chest X-ray, confirming that this is a pleural fluid, not intrapulmonary fluid or not pulmonary abscess. Okay. Another patient, 2-year-old male, presented to the ER after foreign body ingestion removed by NT people, and this is after removal. What you see, this is widening of intestine, and this is emphysema, surgical emphysema here, and also pneumothorax. Okay, you see the pneumothorax here. or pneumomediastinum. You see this? This is abnormal, you can see pneumomediastinum, okay? And this is also surgical emphysema. What's the next step? This is a fluoroscopic study, injection contrast or esophagogram, confirming there is a esophageal injury. It's a little bit here sealed, perforation after a while. And this is cavitary lesion with air fluid levels 7 days later. And this is after insertion of an nasogastric tube which is coiled in the stomach. So that means this is a laterogenic injury of the esophagus complicated by esophageal pleural fistula with abscess formation. This is, it was accessed and big tail catheter was inserted. Pleural effusion, according to the content, can be classified as you know, into emphysema, oxidative, fibrovirulent, and organizing. This is according to the content and also to the stages. Okay, we have to go very fast. Transudate, the most common. Just you can just remember organ failure, lung, liver. Kidney, atherogenic hydrothorax, pulmonary embolism, and peritoneal dialysis. This is the most common. Oxidate, you can remember just the most common cause is the infection and neoplasm. Next, going to one of the procedures done by the pediatric intervention is the fibrinolytic therapy for emphysema. If you have like pleural effusion, and it's very difficult to drain it because it's very thick. Okay, so we can inject fibrolytic agent like TBA, urokinase, or streptokinase. Okay, this is one of the useful technique to accelerate the drainage of the well-organized or turbulent effusion. You have to, this is the doses, so you have to go very fast. Pleural disease is this, when you have a recurrent pleural effusion, so you have to, this is just to obliterate the pleural space. And by an administration of sclerosing agents, such as doxycycline or alcohol, you can use it. But most of the time, we use doxycycline or as one of the sclerosing agents. And this is done usually. One of the most indication is the chylothorax, secondary to thoracic duct injury. Bronchopleural fistula is one of the complications of necrotizing pneumonia, and this is referred to abnormal communication between the pleural cavity and the lung. And also it kind of complication of biopsy, like lung biopsy. And it's very difficult to treat this. You can sometimes try to use injection of like a sclerosing agent to just obliterate the fistula. Pulmonary and mediastinal lesion biopsy is one of the most commonly indicated or requested procedure, like mediastinal mass or lung mass biopsy. And this is an example of indications of percutaneous needle biopsy of pulmonary and mediastinal lesion, focal obesities, focal infection lung lesion, bronchoscopy, which and if not possible to or not amenable for bronchoscopy biopsy, mediastinal masses or lymphadenopathy, focal or diffuse pleural thickening, chest wall masses or fluid collection staging, and also staging of the tumor, and also needle localization for small pulmonary lesion. Okay. The contraindication for the needle biopsy of pulmonary and mediastinal lesion is if the patient are in severe underlying, if the patient has a severe underlying pulmonary disease, or the contralateral pneumonectomy or severely limited function in the contralateral lung, patient with positive pressure ventilation or bleeding diathesis if the patient has a high INR more 1.5. Percutaneous needle biopsy it can be done either under ultrasound or CT guidance, and according to the what's the best image modality used, or and most of the time we use ultrasound just to minimize the X-ray radiation, the radiation. For deeper lung lesion with intervening radiated tissue, CT guidance is the best. So this is an example of pulmonary and mediastinal lesion. We can see there is a very occult or small lesion seen in the posterior in the lateral view. It's very difficult to see it here, but you can see there is abnormal obesity here. Well, partially obliterating the right, the lower margin of the right cardiac border. CT is very clearly visible in the posterior aspect, and you see this is the needle through during the biopsy. This is a real scenario. 5 years old male complaining of constipation. Abdomen X-ray showed cardiomegaly. This is then chest X-ray is requested. So this is the opposite. Sometimes you see abnormality in the abdomen X-ray in the chest, because the proper abdomen X-ray should include the lower hemisphere, the lower thorax. So during the abdominal X-ray showed there is a questionable about cardiomegaly, so chest X-ray requested, and we can see there is abnormal obesity obliterating the right cardiac border, and also it looks like lung or intra or extrapulmonary lesion. So what's the next step is the CT. This is the lateral view, confirming this is anterior, not posterior. This could be anterior or middle mediastinal, okay? But definitely it's not posterior. Next step, show there is a mediastinal, anterior mediastinal mass lesion. And this is biopsy done, confirm it is a lymphoma, okay? Next, this is a small pulmonary, this is an example of small pulmonary lesion. With rhabdomyosarcoma. It's, you can see it by ultrasound, and it was biopsied. Lung tattooing is referred to when you want to inject some staining agent to localize a small lung lesion, and it facilitates subsequent surgical resection. So lung tattooing with IV ATR or immediate video assistant thoracoscopic resection of the lesion is a single procedure. In a hyperdome is safe and effective in children with several inherent advantages, including avoiding the needle to move during the child, and also to to assist the surgeon to localize the region or the area of the abnormality. And this is a sketch demonstrate how we do tattooing. So when we insert a needle under image guidance, then we inject the staining agent. And this is an example. You see, very small lesion. We use this in this image, the CT guidance. And this is the picture after injection of the staining agent, okay? So you see the segment is taking the blue or brownish color, which be easily recognized by the surgeon and easily resected, okay? And this is the hybrid room. So thermal ablation, this is not commonly technique. We for the thermal ablation of lesion like a tumor, and is a minimally invasive technique used to treatment focal tumor, either through the hyperthermic injury, radiofrequency, microwave, and laser ablation, or through hypothermic injury, cryoablation. Radiofrequency ablation is the most commonly used thermal ablation therapy in chest. The liver and the lung are the most common site for this. Balloon trachobronchial tracheoblasty or trachobronchoplasty and airway stenting. This is another procedure. If you have like narrowing of the trachea or bronchioles, we can dilate it through using a balloon or stenting of this this part of the stenotic part. The tips for successful pediatric airway intervention: we have to work as a part of a multidisciplinary team. A combination of bronchographic and the bronchoscopic guidance work together is the best. Use kissing balloon for stenosis at airway bifurcation. Permanent metal stent should only be used as the last option. Give careful thought to the best type of stent to use: balloon expansible or self-expanding or retrievable or biodegradable. Stenting is according to the case. A pneumonated balloon expandable stent may have a reduced capacity for post dilatation. Check this before inserting them. This is an example of this is an example of stenosis at the both bronchus, and this is after. This is the balloon dilatation, and this is after. This is insertion of the stenting here, and this is also after insertion the other side. And this is intraluminal imaging of or the video image of the stent. The last pulmonary angiography, there's a recent advance in non-invasive CT and MRI. Pulmonary angiography has made to the need for or recent advance in the MRI and CT guidance has made a need for invasive pulmonary angiography less frequent. So one of the indication of evaluation of pulmonary hypertension, evaluation treatment of pulmonary evidence, and also post-cardiac surgery assessment of intervention of congenital cardiac anomalies, pre-retrieval foreign body in the pulmonary arterial tree evaluation, clinically suspected pulmonary embolism or foreign body. And this is an example. This is a patient, real patient, 7 years in the presented incidental finding of oxygen desaturation down to the 85%. You see there is a abnormal opacity. Maybe it's not clear for you. This one, you see, CT showed there is a clusters of abnormal vessels on the left lung, and this is selective pulmonary artery angiography, confirming the presence of pulmonary FM. And this is we target this, and this is the guiding catheter. Injection and also inserting first embolization. So there is non-targeted embolization. The stent is the wire is going down to a normal artery, and this is one of the complications you see. this is the embolizing agent is going to the normal artery, causing infarction. Later on, recanalization was done and the patient was brought later, and the proper embolization of the pulmonary AFN was done successfully. So I don't know if I have extra time. Still, we have maybe 5 minutes. Hemoptysis and bronchial artery embolization is part of the angiography, pulmonary angiography, and the most justification of the causes of indication of such procedure is cystic fibrosis, inflammatory condition like tuberculosis, or tumor and tumor-like conditions. Indication in children, mild hemoptysis tend to be mild and self-limiting. Life-threatening hemoptysis in a child has been defined as more than 8 ml per kg in 24 hours. In general, bronchial artery embolization is recommended when other measures have failed to control major or life-threatening hemoptysis. So the classification could be one of the, sorry, this is the last procedures are done on the the last slide here is about the vascular anomalies in chest, and the most important or the most common vascular anomalies in chest is the lymphatic malformation and venous malformation. And the ISFA classification of the vascular anomaly is very important to everybody, and they classified the vascular anomaly to 2 groups: tumors and malformation. And this is initially done by John Malkin and at 1996 or 92, and ISFA was founded by in 1996. So the vascular anomaly classified to 2 major categories: tumors and malformation. And the most we are concerned about the malformation here, and the most common is the venous malformation and lymphatic malformation. And I'll give you, this is an example. This is MRI, showed multicystic fluid density, large lesion seen on the invading the left hemothorax chest wall. And there is no fellow bleeds, and also ultrasound confirming, it's not shown here, that this is a cystic or a fluid containing lesion. So this is a venous malformation. The treatment, the best option for this is the sclerotherapy, and we usually use the 3% tetrasodium sulfate and tetradecyl 3% sodium STS, sodium tetradecyl sulfate, and according to the patient weight. And usually we treat the patient in 3 subsequent sessions, 6 weeks apart, and it's very shows excellent result. The last is that this is an example of lymphatic malformation, soft tissue swelling, significant. Ultrasound showed also this is a cystic fluid containing lesion. There is no enhancement by MRI, and this is the photo of the image. And this is an example of lymphatic malformation. It's very usually successfully treated by injection of doxycycline after insertion of a small big-tail draining tube. Esophageal intervention, like esophageal dilatation. I need to finish here, so I have to be a little bit fast. The last procedure is esophageal intervention. Like esophageal stricture are common problem in children, and they are almost exclusively benign. The most common cause is worldwide as anastomosis, narrowing following the surgery for esophageal atresia, and corrosive ingestion. And this is an example. This is a stenotic part here in the esophagus, at the mid-esophagus. And this is, it showed here after the balloon dilatation. And this is, you see that there is a waist here after the balloon dilatation. And I think this is the last slide. Thank you all for nice, for your nice,
Yes.
Thank you,
Yeah.
your audience. And I'm sorry to be a little bit late.
Still, we have time. Thank you very much, Dr.
So I'm happy to. I'm
Yeah,
happy
yeah.
to listen for any question or refer.
Yeah, yeah. Sure. Thank you very much. Yani, I think you showed to us how much we can gain information from X-ray, where some yani people, they just jump on CT scan, and you show it by evidence. Really, we need to go back and read the X-ray and show. It's very, very important. My question is about some of the question raised about septation. What is the best modality, I mean, to see septation? Is it by ultrasound or CT? And what do you think?
This is a common question, and the most
Yeah.
whether there is a septation or not.
Yeah.
In practice, it's very difficult to say this is a septation, and if there is a septation, doesn't mean anything. Okay.
Mm-hmm.
The most important is the consistency of the fluid itself. Is it thick? Is it turbid? Or is it very clear? Okay, easily drained. Okay. Most of the time we see a septi in the ultrasound, like the image I showed to you before. But doesn't make difference, because if you insert the needle and you just push the guide wire, it will break all the septi. Okay.
Yeah.
And you can follow after if you think there is no significant improvement according to the output of the drain. If it's like the drain, significantly decreased, and still there is a abnormality in just X-ray, that means still there is a residual, and you can ask for ultrasound. And sometimes you insert another tube. If it's there is maybe another loculated fluid, you might need to insert another tube. And sometimes you need to upgrade or upsize the tube you used it before. If it's like 10 French, you can use now, remove it and insert another 10 or 12 or even 14 French. Okay.
Okay. That the other question is related. I mean, is there any rule of MRI in BIEMA? I mean, MRI for the lung, or still we are depending on the CT scan?
Actually, it's not CT and MRI. It's ultrasound.
Yeah.
Okay? If the patient is septic, looks septic, and the patient is febrile, and there is a pleural effusion, so most of the time this is a embayema. Okay.
An embayema, yes.
Yeah. So it's an embayema, and that means it's infected fluid. You can anyway, if the patient is symptomatic, you can just straightforward ask for a chest tube, and you can, after that, if you have a clear fluid, you can check it. You can check it. Send it for analysis. But if it's frank bus, you can see it. Okay.
Okay.
So I think the role of CT and MRI here is very, very low. Okay. Very limited.
Okay. I mean the MRI for the chest assessment. I mean for the thorax. Is it still a good modality to assess the lung tissue? No. To assess the lung tissue. Do you think MRI is good if it's indicated?
Now it's the role of MRI is increasing now, because they try to limit the use of a CT. Okay. Time it's limit the use of a CT, and it has a role in pleural effusion. If you want to screen the thoracic or lymphatic channels. Another alternative for that, what we do it in our hospital, and maybe Dr. Mansour, he remember one case, Mansour, and Dr. Adel, maybe he's aware of that we use intranodal lymphangiography. So we going to the groin and target one of the groin lymph nodes, inject a stain or contrast, would going up to the thoracic or to the lymphatic duct, and would indicate sometime the abnormality, like if there is a leak, would causing a chylotherapy. And this is in the same time,
Clear.
it can be diagnostic and therapeutic in the same
times. Good.
same time.
And thank you very much. Great talk, and from expert radiologist. Thank you very much. And I think now we have a break for Maghrib prayer around 20 minutes. We'll come back to have an asthma workshop case scenario. Will be chairperson Dr. Nasser Al-Harbi, and I think it was very good, very excellent, and a great talk. Thank you very much.
Sorry, and thank you all, and sorry for delay, because this is, as the Dr. Adel said, it's was like
you do great. You do
noticed,
great.
but it's my pleasure to be with you guys. Thank you.
You do great.
Thank you so much, Dr. Saeed. Yeah, really, and for the second time, and always, it's not the second time.
It's my pleasure to any time, Dr. Adel.
It's short notice, and you are not in the country, and despite of all of this obstacles, you made it. You are really did a great job, and
I wish to be informative and good for you.
It is.
Thank you all.
It is. Shukran. Thank you, Dr. Rashidi, as well, Dr. Isa, for your moderating the session. It was really very successful. Just of a note, the Zoom is reached its capacity 3,000. So I would like other colleagues that they would like to watch our scientific program. It's live streaming through the YouTube channels, SPBA Live at YouTube, because it's a limit. So we cannot exceed the 3,000, because also the Saudi Commission, this is the agreement that 3,000 is the maximum. Anyway, we would like to congratulate our colleagues who are behind this successful meetings, especially in the scientific committee and the organizing committee, and all speakers. I'm sure this number came because the program is excellent and the speakers, they are really great. So as Dr. Isa mentioned, we'll have a break till 6 p.m. and then we'll resume our second workshop, which is again very exciting, very amazing. It will be chaired by Dr. Nasser Al-Harbi, and it will be run by both Dr. Saleh Al-Harbi and Dr. Amon Al-Bloui. I wish you very successful, again, another second workshop. And don't go away. Please be tuned, and let's start at 6 sharp, please. Thank you.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
أحتاج شير سكرين طال عمرك.
We will start. So.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. I would like to, this is Dr. Nasir Harbi. I'm chairing the session. I would like to congratulate the organizing committee for the kickoff of this great conference. And without any further ado, we'll start the second session for today. The first speaker with us is Dr. Saleh Harbi, who's assistant professor in Al-Qura University and a consultant pediatric pulmonologist in Dr. Sulaiman Al-Faqih Hospital. Today we'll have case scenarios, pediatric asthma case scenarios, and until Dr. Saleh share his slides. Yeah, the floor is yours, Dr. Saleh.
Assalamu alaikum. Thank you, Nasir, for this nice introduction. Thank you, the organizing committee, Dr. Adil, Faisal, and everybody. So I will start my few cases. It's better to that we discuss those cases face to face, and then we get the flow of the cases. But now what I will do, I will give you the scenario of the case, and then I will go to the, theoretical part regarding the cases. So without any further delay, I will start with the first case. So 18-month-old baby referred with a history of recurrent wheeze or wheezes from the age of 4 months. Parents confirm the whistling noise on breathing out, and they have actually a video clip on their phone to confirm this. His general practitioner also confirmed it's on several occasions. The wheeze was associated with shortness of breath, which respond initially to salbutamol. Following the first episode, the child admitted for 2 days, treated with inhaled steroid, confirmed to have an rhinovirus infection, and since then, he got a recurrent wheezy episodes almost every month, and the most recent admission was for 10 days, including or admitted in the PICU. On all this occasion, he was given a treatment on oral steroid. So he received a frequent oral steroid because of the frequency and the nature of the symptoms. He received an oxygen and nebulized bronchodilators. He had symptoms in between episodes. It seemed to get very severe wheezing illness when he had the flu-like symptoms. Systemic symptoms, no other significant systemic history. There was no actually paternal history of smokes. the mother was got history of asthma. There was a history of allergy in the child, especially in eczema, but there was no food allergy. Birth history, he was born at a full term with no neonatal respiratory or bowel problems. So there is no chronic diarrhea, chronic GI symptoms. On examination, his weight and height on the 5th percentile, there was a chest deformity, and the chest was completely clear on auscultation, and there was no concerning feature on the systemic examination. So very important, because of the recurrence of the symptoms, and the child get that his weight and height, although there is no GI symptoms, so in the 5th percentile. So what we'll do next for the child, how are we gonna look at the child to reach the diagnosis? And the common question that it will come in your mind, if this is something congenital or acquired, if this is an asthma, so the most common thing. So every time you have to ask yourself, because the child received the frequent steroid, frequent inhaler and nebulizer, so is it an asthma?
Dr.
Every time whenever you have it, Aywa?
The screen, I don't know, for me, it's not appear the sharing screen. Your slide session.
Thank you for informing me.
I don't know if you did this on purpose, Dr. Saleh, but we can't see any slides. We see your profile picture.
Actually, I don't know what's the reason anyhow. Okay, so here, so I'll try. Sorry for the technical things. Anyhow, so as I mentioned in the examination, but then I will go with the. So if I have a child like this, frequent wheeze, so we have to think and ask about, is it something genetics? Is the wheeze related to the preschool children? Is it something perinatal related? What about the host factors? What about the postnatal environment? Is it something transient or gonna be a chronic? So every time you have to ask yourself, and then you have to make sure about your differential diagnosis. So is it a lung-related things? Recurrent bronchitis, for example? Is it an asthma? Recurrent pneumonia, for example? With the early recognition, so foreign body is very unlikely. What about cystic fibrosis? There was no GI symptoms, but the child is not that thriving well. So he was in the 5th percentile. And you know, some of those cases, initially, they can have an obstructive airway disease and they have partial response to the bronchodilators. So is it something congenital because of the early start of the symptoms? What about other non-pulmonary, for example, cardiovascular? Is it a vascular ring? Is it a GI? Could be a reflux, swallowing dysfunction, and etc. So every time, whenever you have a child in this age and the early episodes of the wheeze, you have to ask yourself those questions. And you have to make sure what we are going to look for. Then you can ask for even, is it a common or rare? So usually we come for common infection, inflammation. This could be a recurrent bronchitis and asthma, and etc. Very important, when you have a case like this, you have to do your diagnostic approach. So you have to ask about the history. What are the age? Yes, maybe this child is diagnosed at 4 months of age by physician, but if that sound initially was there since birth, then you have to ask yourself, what about other symptoms? What about the onset? If there is any recurrent fever and cough and runny nose, if there is any family history specific Yes, there is a family history in this child for asthma. Neonatal deaths, for example, child diagnosed with a cystic fibrosis or a family history of cystic fibrosis to other chronic lung disease. Differential diagnosis, you have to ask about them. So when you have a child like this, you have to ask yourself, how old was the patient when wheezing started? That's to differentiate, very important differential part. Is it a congenital or non-congenital acquired disease? Did the wheeze started suddenly? So in case of foreign body, what about the pattern of the wheeze? Is it an episodic asthma or persistent? It could be a congenital or genetics, for example. It is associated with cough, like in reflux, patient with asthma, patient with allergies, and others. Is it associated with feeding, like we mentioned in GERD? Is the wheeze associated with a multiple respiratory tract infection, patient with immune deficiency, cystic fibrosis? Is it so that's in a specific season for episodic asthma? And etc. And you ask about the family history of wheeze. So you have to go in details, especially this child. There is a family history of asthma, and there is a personal history of atopy, or this child came with a moderate eczema. So you have to look for the allergic triads, and we'll talk about it later on. Then you have to do your physical exams, so about general examination. What are the respiratory signs and symptoms you have to look for? Any other symptom involvement and finding? And if you want to make sure about his asthma, you have to look for about the cough. Is it a recurrent every time the child will respond to the bronchodilators? Is it the cough occur with an exercise, laughing, or crying? What about the wheeze, pattern of the wheeze and the triggers? What about the difficulty of breathing? Is it during an active exercise or wheeze? The child will have an associated with wheeze and others. And we mentioned about the therapeutic trials, although the child showed initially that it was a good response to the bronchodilators and the steroid, but later on showed that infrequent or a partial response to the initial asthma medication or treatment. And then you can look for also the asthma predictive index. So in this child, if you are looking for the major criteria and the minor criteria, there was a parental history of asthma and the child diagnosed with an eczema. So there was two major actually in this child. So that will increase the risk of asthma during the school age children, but not at this age. So the summary for the case and the diagnosis, there was a history of wheeze from birth. That's most likely, this could be a trachomalacia or bronchomalacia. And what the child diagnosed could be a two pathology, for example, the family history of asthma, wheeze. However, sporadic coryzal symptom also raised the suspicion of an interrecurrent viral lower respiratory tract infections, because the child got most of the time moist cough for a month. So this could be a protracted bacterial bronchitis, should be treated with antibiotics for 4 to 6 weeks, for example. Then you have to, every time, whenever you have a child, especially a new onset or a new case of asthma or a wheeze, you have to ask yourself about those common questions. Then I will go to the second case. So this is the child. He's 5 years old child. He came for an 6 emergency visit for asthma in the last year. He was diagnosed before with asthma, and he began on the albuterol, and they gave him the old style treatment, cromolone by home nebulizer 4 times daily. The wheeze associated with the shortness of breath, and it responded initially to the salbutamol. The child, he received a 3-day course of oral steroid, giving an asthma action plan, and the dose of beta-2 agonist increased because of the increased the symptoms. So at the age of 3 months, after 3 months, the mother came very pleased and reporting the child was done markedly better, has occasional exercise intolerance, awaken only 2 to 3 times weekly, 1 ER visits. He received 1 dose of oral steroid. So what do you think the next step? Child diagnosed with asthma. He had a frequent attacks. It seemed to be uncontrolled. So in this child, you have to make sure what is the level of the asthma control. So during the last year, the child, he got an uncontrolled because there was a 3 feature suggestive of uncontrolled asthma. There was a daytime symptoms, limitation of activity, and there was a nocturnal symptoms, and he received a frequent doses of inhaled beta-2 agonist, and the child received a few courses of oral steroid. So there was a positive asthma exacerbation. But since they increased the dosage, the child now, he got only partially controlled. So in this scenario, what we will do? What kind of thing? So don't forget the child back is 5 years of age. So that's then we have to look for the asthma stepwise therapy. And maybe you will hear tomorrow about an asthma treatment, the SINA, mainly the SINA guidelines for this. But if you have a child, an action once you controlled, you have to assess every time. So if the child is well controlled, you have to maintain your current therapy. You have to do a follow-up later on. You give him more time. And you consider a step down if the child is controlled for at least 3 months and there was no side effect of the medicine. As this case, so the child is partially controlled, he's not controlled, you have to go a step up, or we'll show you now what we will do. And you have to make sure about the side effect. And if the child is very poorly controlled, you have to make sure you go even sometimes 2 steps up, and you have to do a reevaluation in 2 weeks. Every time you have to make sure about the technique, and you have to make sure and ask the parents about the side effect of the medicine. So in this case, the child is 5 years of age, and this is a SINA approach for a patient. He's 5 to 12 years of age, came with asthma, the stepwise therapy. So what do you think we'll do now? And the child, he saw that he's a partially controlled. So we have then, and he was on a step 2 therapy. So then we have to make sure about every time about the diagnosis, about the technique of the medicine, about the device the child is receiving, and then we will go up with 1 step. So you look for alternative, but don't forget this child, he received the low dose of steroid. So the most common thing that's either I will increase the medium dose of steroid, or I will start him on a combination therapy. Whatever the child needs, more the step 3 and more, you have to consult your specialist. So either allergist or an asthma specialist. So that's every time you have to make sure about the diagnosis and about, you can ask the child about the asthma control test. And this is an assessment questionnaires to assess the child control level 2. You want to look for the children less than 5 years of age. Also, you have to look for the SINA for the asthma or a stepwise therapy asthma management. You can look for the GINA if you wanted to, the same thing. And especially here for the children 5 years of age, what kind of options? And I mentioned it already in the SINA. So the treatment was the child giving that medium dose of inhaled steroid, giving an asthma action plan. His symptom improved and was no decline in the need for attendance at the emergency room, and subsequent there was no hospital admissions. And this is our aim, to either have a normal or near normal life. You have to look for the life quality actually, and you have to make sure the child is not suffering with the school absenteeism. And this is very important, whatever you treat. Because I have time, so I will go to the third case. I'm going to be different too. So this is a 12 years old girl. She came with a history of asthma. Presented to the ER. She got a 3 days history of increased work of breathing, cough, and wheeze. She reported there is no clear triggers at this time for her respiratory symptoms. She had noted same symptom of mild upper respiratory tract infection a few days ago. Within this episode, this patient had been using a short-acting beta agonist more frequent in the past without the expected resolution of the symptoms. On the day of the presentation, the patient awakened feeling suffocated, and her mother noted that lip or turned to be blue. In the emergency department, her oxygen saturation was 85. Respiratory rate, so she had been hypoxic, and tachypnea, respiratory rate is 40. She had significant increased work of breathing. There was decrease in the air entry bilateral both lungs. There was wheezing in the upper part of the lung, and treated with salbutamol and ipratropium bromide, received IV steroid, systemic steroid, and then there was no improvement, so they gave her the magnesium sulfate. Chest X-ray done to make sure there was no pneumonia or pneumothorax, so that's hyperinflation with no focal findings. Her medical history revealed that she was followed by the respirologist for the asthma, and she had a good medication adherence. She had not experienced any significant exacerbation for the last 6 months. There was a had history of wheeze and dyspnea and pruritus with exposure of peanuts, chicken bees, and lentils. So she got a food allergy. 2, she had been prescribed an injectable epinephrine device for the kind of anaphylaxis she had before. However, her device had expired at this time of presentation, and her symptoms episodes have been seasonal and related to the exposure to grass and pollens. She got allergic rhinitis and food allergy and asthma. So positive atopic march, I will talk about in a bit. This presentation occurred during the winter, or the allergic rhinitis triggers. So what do you think is going on in this child at 12 years old? She got an asthma, she had been on the asthma management, but at this time she feels that suffocated, and there was tachypnea, wheeze. So in this case, you have to make sure there was the beginning of the anaphylaxis. So a bit about allergy and intolerance. When we talk about food allergy, we are talking about reaction initiated by a specific immunoglobulins mechanism. If you are talking about intolerance, that's a reaction initiated by an immunological mechanism. So food allergy is an immune system, and the food intolerance is a digestive system. Most of the food allergies gonna be either mixed, IgE mediated or non-IgE mediated. And we have a food intolerance, and that's the non-immunological mediated, as you mentioned. I will concentrate more about the IgE mediated food allergy, like in a case of anaphylaxis, for example, in this case, because we have several examples for non-IgE mediated. So celiac disease, for example, protein-induced enteropathy, Heiner syndrome, all those examples of non-IgE mediated food allergy. And usually when we are looking to differentiate between both the IgE mediated, what our concern in this case, and non-IgE mediated, you have to look for the symptom onset. So usually in the IgE mediated, the onset is less than 1 hour, even 30 minutes. Where in non-IgE mediated, usually the onset more than 1 hour. It takes up to 48 hours sometimes. And the other differential, mainly, sometimes gonna happen, but mainly the anaphylaxis, that's with the IgE mediated. So the respiratory and the cardiovascular symptoms, the persistent cough, stridor and wheeze, the hypotension, sometimes you found the child is pale and floppy, and those are the signs of anaphylaxis. You have to make sure that those children, those symptoms correlated together. For example, this is a good example, atopic marsh. So atopic marsh is a category of a disease related to each other. So the child, they will start with a dry skin at birth, and that's the eczema. And then he will get food introduced. Either the child at the beginning, he will have a formula, for example, cow's milk allergy, or any other types of food, and then allergic rhinitis, at usually diagnosis between 2 years to 3 years of age. And then later on, the child, he will have an allergic asthma. And this is what we call the correlation between those diseases in the atopic marsh. And you know, if you have, that's 2 out of 10 children up to age of 13 have both allergic rhinitis and atopic dermatitis, around 23.7, around 24%. So quarter of those children, quarterly, those children, they will have a correlation between mainly allergic rhinitis and atopic dermatitis, and maybe they will have with asthma too. So this is the atopic marsh. The correlation is very important. Whenever you have a child with asthma, you have to ask about allergic rhinitis, you have to ask about atopic dermatitis, and then you have to ask about food allergy. Which one is the first? Before, they think that the old hypothesis showed that the food allergy will cause atopic dermatitis, but nowadays they found actually atopic dermatitis, the new theory, is predisposed to the food allergy because the atopic dermatitis from the beginning. Because of the time, and have a few minutes to, will show this is the evidence of the atopic marsh. So if the proportion of the infant with a cow's milk allergy experience other atopic condition at 5 years of age, he will have other type of food, 75%, 43% with allergic rhinitis, this is based on a study. 40% they could have an asthma, and 21% they could have atopic dermatitis after 5 years of age. So infant with cow's milk allergy may become susceptible to other allergens later in life. This is a common type of allergies. And the prevalence of the food allergy in children, mainly the milks, eggs, peanuts, and other form of food allergy. Vaccine and allergy is very important. There is nowadays, there's no contraindication for influenza vaccine. And most of the vaccine with cautions, and there is no absolute contraindication. Wherever you have the children, you have an egg allergy. But you have to make sure wherever you give the child a yellow fever vaccine, for example. There was a clinical criteria for diagnosis of anaphylaxis you have to go with. You have to review those criteria to make sure. You have to make sure that what are the integration between cow milk allergy, digestive symptoms, skin symptoms, respiratory symptoms, and the general symptoms that those children they will have. What are the diagnostic tests for the IgA-mediated food allergies? Can we do the skin prick test? Is it the level of immunoglobulins, the RAS test, or sometimes the food challenge that we do it in a certain number of patients? How are we gonna look for the predict for the children that will have anaphylaxis? You have to make sure about the level of IgA, but this not predictive for the severe infection. So you look for the risk factor, especially if you have a child with a history of anaphylaxis, indicate that's high risk of subsequent anaphylaxis. But for the first time, 40% they have a first event. Adolescent and young adult, they are at risk. Delay in adrenaline given deaths or remote geographical location, they are at risk or more risk. Poorly controlled asthma and anaphylaxis, they are at risk also. An allergy to a peanuts or a free nuts, also at risk. Thank you, Dr. Nasser. Thank you, my colleagues. I will leave now the door open for Dr. Amuna. She will give her presentation too. Thank you.
Thank you so much, Dr. Saleh, for this insightful talk. Without any further ado, we'll go for the next speaker, and we'll keep the question at the end of the session. So I may ask Dr. Muna try to finish 5 minutes before the 5 minutes to 7, so we can have 5 minutes to answer the questions. And I may ask Dr. Saleh to answer the questions in the chat as well. Dr. Amuna Al-Baloui is a pediatric consultant pulmonologist in Security Forces Hospital, and she will give another session in pediatric asthma case scenarios.
Hello, good evening, everybody. The screen is clear for you or not?
Yes, Dr.
Okay, thanks. Really, it's my pleasure to be one of the presenter today. I know, as Dr. Saleh mentioned before, that it's really usually we prefer the asthma workshop to be face-to-face, but because of the pandemic, unfortunate, so we have to do it as virtual. But if you have any comment or question or to be shared with us with this case, we can share it with question and we can answer it during. I prefer today to go through a journey of one of the patient we actually see in the clinic. So today we will start about Lama. Our patient was actually come from a local, other local hospital. Actually, she came from outside Riyadh, as the patient was managed there as bronchial asthma. And the patient was she's suffering from her lung issue so we'll go to Lama, then we will go to the other patient. So we'll start with Lama. Lama, she's a 6-year-old girl presented with history of recurrent cough, shortness of breath, and wheezing. So first, the question for us will come, what we will do for Lama first, as the patient, she was presented first to the clinic. So first, as we mentioned by our colleague, history. If we take long time in history, really spend your time and take a history from the patient and their parent. In the first visit, really, Lama, she came with her father because the mother, she was just delivered. So there is some missing in the history. But Lama, as we mentioned, she's a 6-year-old girl, healthy child. She's suffering from her recurrent issue of respiratory. She was well till age of 2 years of age. She started to have recurrent attack of breath and wheezy chest. This cough, actually, it's mainly at night and early morning, with really sometime awaking her from sleep with post-toasted vomiting. The cough, it's increasing with playing, laughing, with when any exertion, usually exacerbated with URTI, dust exposure, strong smell. According to the parent, when she's having this issue, she will cough more. This attack, it's happened every 2 months, which is really the parent going frequently to ER, which need nebulizer and oxygen, and there is improvement after that. The patient will settle, it's improving, and the patient return to her home. No clear history of recurrent infection, but because unfortunately actually seen in outside, and according to the parent, each time she's presented with history of cough, they prescribe for antibiotic. So at this point, we are not sure the patient really she's having asthma or other than which is treating infection. But according to the mother, each time she's going, they treat all. They give her steroid, nebulizer, and antibiotic. So we'll go back to past history. Lama, she's a product of term with birth weight with 2.5 kg, no NICU admission, discharged with the family with good condition. She was well, age of 5 months, she was admitted with RSV bronchiolitis and managed in the hospital and discharged home. After that, she's having on and off cough, but it was not bothering the parent or the child till 2 years of age. She's the first child in the family, and she's having other sibling who's Naif, who's now currently, he's a 2 year of age. He was a than Lama, which was actually at 6 months of age. He's having cough, respiratory, and also diagnosed with asthma as one managed, but he's more stable than Lama. Naif, he's on inhaled steroid and he's doing fine. The other younger sibling, he just born. So he's having no symptom. Mother is healthy, and the father, he's having only allergic rhinitis. the child, she was looking well, active child, interactive. She's actually, her vital sign was all within normal. The weight, actually, it was in the 5th centile. But when we asked the parent, they said there is no losing of her weight. And this is the usual for the family. All of them, they are thin. But we are, because the first visits, we are not sure about the patient. There is no clubbing. ENT examination, she's having large tonsil, but there's no nasal polyp. Heart normal, S1, S2, no murmur. Chest at that time, it was equal air entry bilateral with a prolonged expiration and expiratory wheeze. So just we will go through SENA diagnostic asthma history. So history of multiple attack of shortness of breath and wheezing in the season, which really we found it in our patients. Coughing more than 2 weeks, not related to RTI, recurrent and worse during sleep and trigger such activity, laughing, crying, exposure to tobacco, smoke or air pollution. Reduced activity, as per the parent, Lama, she's not actually active a child. She's very quiet and she's prefer to play while just watching TV. And we don't know this is related to her cough or because the child is really quiet. Wheezing, it was at that time equal both sides with expiratory phase. There is family history of allergic rhinitis and the breath sound was prolonged bilateral. So by this, we in that the patient is most likely she's having asthma. So next, we go to the guideline for patient, SENA guideline for patient from 5 to 12 years old. And as the patient this is the first visit for her, it's very difficult at that time to assess the control. But we step the patient and we start the patient in inhaled corticosteroid as the patient never been started in medication. So we discuss with the parent during this visit, what the medication she will be on it, how they will use, and the importance of adherence, compliance, technique, and also the risk factor and exposure. After that, we prescribe for the patient and we give her follow-up. So we're back with our patient after 6 actual week, we saw the patient back. Lama, she came. Parent was at that time really happy, but still, according to them, there is some improvement. The patient, at least she starts, some of the nights she's sleeping more comfortable, but still, when we take more history, she's still having coughing at night. She needs to use a bronchodilator around more than 2 days per week. And she's coughing with exertion. So at this time, we have to go back to our evaluation. So what next we have to do? Still assessment back. According to our physician assessment control, Lama, she's having more than 2 days per week. She's having daytime symptom, limitation of activity, night symptom, and she's using bronchodilator. So more than 3 from partial control that I'm dealing with uncontrolled, most likely asthma. So we have to go back and we know how to assess the asthma control. As we know, the physician assessment control, and we have other patient or caregiver assessment control depend on the age. As we know that age 5 to 12, which Lama, we have to assess the children. This is actually the assessment in general. So uncontrolled bronchial asthma, we have to deal now by one. So we go first, we challenge first our diagnosis. So when we challenge our diagnosis, we have to look for, am I dealing really of asthma uncontrolled? So what that mean? That the patient really asthmatic, but still control, and we need to do more increase or step up from her treatment. Or I'm dealing with asthma with comorbid disease. What that mean? As we mentioned before, other allergen, other GERD, patient having other disease like cardiac. It's asthmatic, but he's having other comorbid disease. When we take the history, the patient actually, she's having snoring, sleep sometimes disturbance. According to the mother, all the time she's having runny nose with thick secretion. So if she's like her father, she's having allergic rhinitis or not. The third thing, I'm dealing with asthma mimicker or not, and we will come later on it. So we have to go full history again for this patient. Second, we will look for environmental factor. So we have to ask the parent for each smoking in the family. And if the father is a smoker, also if he's smoking outside and come with the same cloth, that means it's still the child, it can be irritant. Any chemical. Don't forget, in our country, as you know, all of them, they are using bukhur, which really it's irritant for the child, or any asthmatic bit in the family, any farm or garden near to it. So we look for all environmental factors. Third, we have to go for asthma education and evaluation of compliance. So we'll go for short video how to actually assess the asthma. So how to use MDI and spacer. Don't be surprised in the clinic, you will find that the patient is not using the improper technique. So as you see, we have to use and we have to be used in good technique. As you see, the patient have to be used, depend on the age, and we will go for each one. So if the spacer is new, so we have to shake it before and priming the MDI if it's a new. If not, we will use it first. As we see here, the child, he'd have to stand or sitting position, and it have to have really good sealing around the mouth. So sometimes it's very difficult for the child to hold, so we will explain to the parent, just let him take a normal breath and they will count to 10 and move it. And we'll repeat it as we see on this video. Don't forget, actually, after each inhaled corticosteroid, to ask the parent to clean the mouth. Sometimes very difficult for a small child, so we'll tell him to give him some water to drink. So other issue, the cleaning of the, so we have to be sure the parent, when they know how to deal with the spacer, and they have to clean it and not to be dry it with any towel or something, because this will affect the patient. So this is in general. So as we see here in our choosing of inhaled device for children, for less than 4 years, we prefer spacer with face mask, 4 to 6 with mouthpiece, more than 6 with mouthpiece. And you will find a lot of children in more than 10 years of age, they are really confident to be used without a spacer. But really, when you ask him to illustrate during the clinic, they will be really use it in wrong technique. The other, be familiar with the medication. Ask the parent. It's very difficult for the parent or the child to notice their medication. So ask them what the color. As you know, orange is Flexitide, purple is a combination, it's a Seretide, and sometimes gray or blue, it's a inhaled salbutamol. So ask them how they use it, and let us illustrate it during the visit. So this is what we have to actually during each visit to be covered. Patient identification, list of the medication, asthma control status, suggest action of asthma control, how to use the inhalation device, and when to seek medical advice. So we'll go back for our patient. So after taking a history, we find the patient she's uncontrolled, but still we are not sure we are dealing with asthma or not, but we prefer to step up the medication as the patient, there is some response. So we step up the patient, we add a leukotriene modifier. So we add singular with low dose inhaled corticosteroid, and then we give the patient follow up with some investigation we will do for her. So Lama was come again to our, but unfortunate now there is other history. The patient is she's having symptom, and according to the last 2 weeks after she's having a URTI symptom, still coughing with really the secretion, it become very thick. It's yellowish, dark yellowish in color. So at this time, we prefer the patient still uncontrolled. We go again to challenge our. So when we challenge our diagnosis, we take full history. The child actually in between the attack, she's not really back to normal. There is partial response, but according to the mother, not when she younger in age, the response was better than now. She's still coughing all the time, still with any exertion, she's having cough with really very thick sputum. With the mother, she said still early morning, the child is producing a lot of secretion. Other thing, the patient, she's having also history start to be affected. By examination, the child still, she's not having any clubbing. She's looking well, very big tonsil, and also she's having decreased air entry in left side. So we prefer now, we are challenging our diagnosis. Am I dealing with asthma or not? By this finding, we have to be sure. So this is actually asthma mimic should be suspected when you find it in the failure to thrive, onset of symptom during infancy, vomiting associated with respiratory symptom, continuous wheezing, failure to respond to asthma controller, clubbing, focal auscultation, and not associated with typical trigger. This is now we found in our patient. Patients start to be failure to thrive. Actually, from the last visit, first time we saw the child, she's not gaining weight and she started to crossing centile. It not seems to be something familiar. And still she's continuous wheezing all the time, failure to respond to asthma controller, and she's having focal auscultation. So we prefer this time to admit the patient for evaluation. So now clinical suspicion of asthma mimic is an acceptable indicator for chest X-ray. But as we know, if the patient asthmatic, not all, it's recommended to do chest X-ray. So this is the chest X-ray, as you saw here in the retrocardiac. There is really a collapse. So the patient being bilateral, hyperinflated, and there is retrocardiac atelectasis. So CT was done. The patient actually, she's having some element of bronchiectasis and she's having left lower lobe collapse. So patient bronchoscopy was done and sputum culture revealed that the patient, she's having Moraxella catarrhalis and strep pneumo, which is both, it's common to be in the lung. But the patient, when we take history, also she's having very thick secretion. So sinuses was done, there is thick sinus, and there is picture of pansinusitis. So the issue is still, the patient, she's not having any history of diarrhea. She's taking orally well. There is no steatorrhea. There is no recurrent infection other than sinopulmonary. There is no other infection was noticed, only lung and sinuses. But the issue, the patient weight is affected. So we go back to the history. So still the patient, she's affected. So we prefer that we are not dealing now with asthma and further evaluation have to be done. History was taken and the patient at that time was referred to, we have to refer the patient at this point to specialize. So the patient actually, immunoglobulin was done and it's all within normal. Sweat chloride done also is normal. There is no steatorrhea. She's not having any element of immune deficiency after further workup of immune deficiency. The patient, she's having most likely primary ciliary dyskinesia and genetic testing was done and confirmed the diagnosis with primary ciliary dyskinesia. As we know, the patient is not typical for its presentation initially. Because of failure to thrive, it's guiding us to other diagnoses. But the issue, primary ciliary dyskinesia, can asthma, and there is partial control with a partial improvement with the bronchodilator. So this is the first case with our patient. It's primary ciliary dyskinesia, which is mimicking asthma. The next case we will go is very quick. This is Omar. He's a 6-month-old boy who presented actually with history of difficulty in breathing and shortness of breath. The patient actually, he was present the same at 1 month of age with history of cough and shortness of breath and wheezy chest. So they were diagnosed as bronchiolitis, managed and discharged home. But after that, he had frequent visit to the ER for nebulizer. He need, each time they said there is noisy breathing, there is no confirmation if wheezing or not, was noisy breathing, and they was giving Ventolin and discharge home. Actually, it's more than 4 times he present to ER. Because of that, was referred to pulmonologist. So now we have a question. Am I dealing with early transient onset of asthma or I'm dealing with other? We know that the early transient onset of asthma can be present less than 3 years of age. Still, because of early presentation, we have to think more of history. So we apply the modified asthma predicted index. What that mean? Asthma predicted index, that means it's for children of a history more than 4 wheezing, and he's having either 1 major or 2 minor criteria. When we predicted in the patient, actually he's not having any of it. So we are not dealing really with asthma. So we take a history again. The patient, he's having history of choking with feed. He's thriving well and partial response to bronchodilator. So because of choking with feed, we think that am I dealing with patient with GERD, but the patient really thriving well, but we prefer to do barium study. And as you see here, there is posterior indentation, which is after really patient was referred and operated, and the patient really after that, he's asymptomatic. So we'll summarize now actually what we have to do for the patient with asthma. So in general, this is the SINA guideline about approach of patient for outpatient asthma, children less than 5 years or more than 5 years. First thing, you have to assist physician, actually assessment of asthma control. So how we can assist the asthma control, as we mentioned, there is a physician assessment and there is a patient or caregiver. You have to look for control, partially control or uncontrolled. For control, if you have a patient control, so after follow-up for 6 to 12 weeks, we can downgrade the treatment. And if the patient partially controlled or uncontrolled, we can step up the medication. So after that, each time you assess and you need to step up, you have to do challenging your diagnosis, environmental control, education, evaluate the compliance and risk assessment. So this is for the patient less than 5 years of age. As we see here, just the different actually for step up, most of it, the LABA, it's only in the more than 5 years of age. And this is actually what we was done with our patients. Sometime with 1 point, we will reach a diagnosis of asthma or not. This is history that favor of diagnosis of asthma, intermittent episode of wheezing that usually are as a result of common trigger, seasonal variation, family history of asthma or atopy, good response to asthma medication, and positive asthma predicted index. Asthma mimic should be suspected with failure to thrive, onset of symptom during infancy, vomiting associated with respiratory symptom, continuous wheeze, failure to respond to asthma controller medication, clubbing, focal auscultation, and symptoms that are not associated with typical trigger. This is a picture of patient, the first one and up. This is a nasal polyp. This patient was referred at age of 5 years, actually, with history, failure to nasal polyp, was managed with as bronchial asthma since birth. His symptom was started actually since birth. But actually, after we saw the patient, he's having all the picture of cystic fibrosis. He's having nasal polyposis, he's having rectal, he's having clubbing, and he's having recurrent chest infection. And when we take sputum culture, Pseudomonas growing, and he was managed for a long time as bronchial asthma. And the other picture is patient with clubbing. So when to refer the patient in specialist, if there is uncertain regarding the diagnosis, there is difficulty to achievement and maintain control of asthma, or if there is biological therapy or immune therapy is being considered, if the patient requires step 4 care or higher, if the patient have asthma attack requiring hospitalization or 2 or more or oral corticosteroid in the past 12 months. So this is a list of most common asthma mimicker, which is really, we can see, as you see, perinatal or family history, symptom present at birth. We can think about chronic lung disease, prematurity, ciliary dyskinesia, cystic fibrosis, other like severe upper respiratory tract disease, ciliary dyskinesia, symptom and sign, persist moist cough. You think about protracted bacterial bronchitis or bronchiectasis, or for any cause. There is a lot of disease. If you have dysphagia, you think about swallowing problem instead of asthma. If there is breathlessness with tight and dysfunction of breathing, inspiratory stridor, it's not an asthma. And also focal sign of a chest, you have to think about foreign body or like the primary ciliary dyskinesia. So this is actually a list of some disease we can cover as mimicking of asthma. But at last, actually, still common is common. Bronchial asthma is a common disease, and it's a burden for the child, for the parent. Establishing diagnosis of asthma involves careful process of history taking and physical examination and diagnostic study. Other way, clinician must maintain high index of suspicion that mimic asthma, particularly when the patient presents atypical or fair to response. Many different surgical, medical condition can trigger symptoms. That fact should be considered when the child undergoing a diagnosis. Although some symptoms may mimic asthma, they are not necessarily related to the lung problem. And thank you. Any question?
Thank you so much, Dr. Mona. Thank you, Saleh, also for your fruitful cases discussions. Now we'll just screen the questions. First question is about the treatment differences between congenital and new onset asthma. Although I have objection about the terminology used, but I can direct this question to Dr. Saleh. Is Dr. Saleh around? Dr. Mona?
Yes, Nasser, but I have difficulty in the internet here.
Okay. We can hear your voice, Dr. Saleh. Can you hear us, Dr. Saleh? Okay, Dr. Mona?
Yes, doctor. About really, I'm with you that regarding the question is really there is no congenital asthma, as you mentioned that they said congenital. So if we reach maybe they are actually we can change the question. If you have patient with early onset, you have to think with other differential diagnosis. But if you reach that the patient is asthmatic, the management is the same. I think this is the question. It's really I don't understand the question.
Sorry, Dr. Amuna, I think he's asking about the congenital and acquired wheeze or causes of wheeze. So
acquired
on the type,
this is different.
On the type
if wheeze,
of wheeze,
yeah.
actually. Yes, because we don't have
maybe the type
asthma.
of wheeze is
yes,
different.
Exactly. Yes. So it depends on the differential diagnosis and the cause, the main cause for that. This is the answer.
Sure, Dr. Saleh, another question. I think two questions and one, the value of
go ahead. Yes.
aero allergen RAS test. Another question also about the utility of allergic skin test and IgE as well in asthma.
Yes, and I mentioned it, Nasser, there. Already, that's when I put the slide for the difference between the RAS test and others. So the RAS test usually looking for the level of the immunoglobulin, IgE mainly. So the sensitivity according, so it's going to be 50% specific. Few cases that 95% that's depend on the children with there is underlying atopic dermatitis and who's allergic to the eggs or milk, peanuts and fish. But it's more expensive and sometimes it takes a few days or weeks even to get the result. For the skin prick test, 85 sensitive, the sensitivity. But it could be up to 60% specific to a certain type of food. So you have to make sure about it. And they need also to need an expert person to do. So we have to do the way there is just the benefit. But go back to the history. The main part is the history and the history and history. And then after that, you can confirm by the skin prick test or the RAS test according to the price, according to the patient satisfaction, and according to the allergens itself.
Sure. So the clinical indication is, I mean, the indication is purely clinical, and the value or the utility of these tests you already elaborated in your talk.
Yes,
I have another question.
Yeah, but just because I want to highlight something, Nasser, sorry, the food challenge should be done by the expert. So don't do it in your clinic alone. You have to have a setup for the food allergen challenge.
Sure. Another question is about how to diagnose asthma-related remodeling in clinical practice. Actually, this question, we'll leave it for the session tomorrow. There will be a difficult to treat asthma session. Another question is maybe directed to Dr. Mona. It's about the primary serious dyskinesia. How you treated your patient after diagnosis with the primary serious dyskinesia. I think this is beyond the scope of this session, and I think tomorrow or after tomorrow, there will be a talk about primary serious dyskinesia. Another question is at which age we can label individual as asthma. And is there a terminology called hyperreactive airway disease? Dr. Ramana? Dr. Ramana, we can't hear you.
Okay. Regarding what can diagnose, we can diagnose at any age. We can diagnose the patient, as we mentioned, if we are really sure about the diagnosis. We apply the modified asthma predicted index, and we see the patient how he's having to have persisting asthma or not. But in younger age, we have to be sure that the patient is asthmatic or not. As we mentioned, that early presentation in infancy, we have to think about other diagnoses other than asthma. This is what I think. No more we use the hyperreactivity airway. It's still that we can follow the asthma phenotype, early transient, late asthma, or persisting asthma. I think if there is any comment from other colleague, I think they can add.
About the terminology hyperreactive airway disease.
I think hyperreactive airway disease previously was mentioned that the patient is still, they cannot, long time they said that below 2 years of age, not as asthma. But nowadays with actually the asthma modified index, and by this, we can label the patient as asthma.
Okay, so I think this is not a diagnostic terminology that we used to describe asthma or to label patients as asthma. Okay, some request for this lecture. I think the talk is being recorded. Infant, so it's more, you can get the recording, I believe. So another question, infant with recurrent wheezy chest, maybe this is the last question we'll have. Infant with recurrent wheezy chest, very common in clinic. What is the differential diagnosis? I think you mentioned that. I think I will thank you again, Dr. Saleh, Dr. Ramona, for your fruitful discussion. I will close the discussion here. I would like to thank the organizing committee for the invitation, and we'll proceed with the second session. Thank you all.
Hello?
Hello, sir. How are you?
I'm doing well. This is Hank Meyer. I'm the speaker on non-invasive ventilation, Dr. Meyer.
Good to see you, Dr. Maya.
Very nice
I'm
to see you.
I'm Khalid. I'll be chairing the session.
Okay.
You got a
Should
few
I
minutes?
put my should I put my slides on or not yet?
Let me just introduce you, and as soon as we introduce you, we'll hand it over to you.
Okay, perfect. Thank you.
Thank you. طيب بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على نبينا محمد وعلى آله وصحبه أجمعين. I want to welcome all of you to this session on non-invasive mechanical ventilation. I want to start this session with a quick note. I would like to congratulate His Majesty, the custodian of the two holy mosques, King Salman bin Abdul Aziz, and His Royal Highness Prince Mohammed bin Salman, Crown Prince, on the occasion of the founding day of the Kingdom of Saudi Arabia 300 years ago. And this conference could not have come at a better time when a country celebrates 300 years of success. And it's a source of knowledge that shines the whole world. This session is attended by close to 3,000 participants or attendees, and it's an honor and a privilege for us from the state of Pennsylvania, from the city of the Liberty Bell, the cheese steaks, and the brotherly love city to welcome our honorable guest, Dr. and Professor Oscar Meyer. Professor Oscar Meyer is an attending pulmonologist within the Division of Pulmonology, where he is the medical director of the Children's Hospital of Philadelphia Pulmonary Function Testing Laboratory. For the last 17 years, he has been the pulmonologist in the Neuromuscular Center, as well as in the Center for Thoracic Insufficiency Syndrome since its inception 10 years ago, where he directs much of the outpatient and inpatient management of these patients. He has broad clinical and research interest, including managing patients with chronic respiratory failure, the pulmonary manifestation of neuromuscular disease, and assessing and managing patients with complex chest wall and spine diseases. He has been an active member of the Asthma Clinical Science and Research Group at the Children's Hospital of Philadelphia, which established standard of care for asthma within the hospital. Dr. Meyer is on a number of national committee and study groups involved in pediatric pulmonary function testing, the assessment and management of children with complex thoracospinal disorders and neuromuscular disorders, on which he has lectured and has published a variety of journal articles and book chapters. It is an honor and privilege for us to have you with us today, Professor Meyer. The mic is yours.
Thank you very much for that very generous introduction, Dr. Khalid. I'm a little embarrassed that cheesesteaks made the list of things to mention related to Philadelphia. We have plenty of other more palatable and healthy food opportunities. But with that, I would like to thank the organizing committee also for this very honorable privilege to speak with you. Going to be giving two lectures, one today and then one on Saturday morning, related to non-invasive ventilation. This talk will be some of how to structure non-invasive ventilation for a patient. And then on Saturday, we'll talk about how to set up an effective way of doing this both in the hospital and then most importantly, management at home. So with that, we'll move forward. Oops, let's see. There. Can you see my slides advancing? Outline? I just want to make sure.
Yes, we can see them very clearly.
Perfect. Okay, thank you. So we'll talk about 5 general categories of things. The first is when we're talking about non-invasive ventilation, the question first is what are we trying to support? And then assessing the need for the support, which then feeds into what options are there for support. And then when you determine that you want to use non-invasive ventilation, there are a number of parts to that that need to be managed and customized to the patient's needs. Then we'll finish by talking about some of the different modes of support for non-invasive ventilation. So what's being supported? Probably most commonly, non-invasive ventilation is used for supporting obstructive sleep apnea in patients that have a narrowed or floppy upper airway. But in neuromuscular disease in particular, we use it for supporting ventilation. In addition, it can be used to support patients that have low lung volumes. And this is quite common in patients who are born prematurely, patients with bronchopulmonary dysplasia, where the respiratory mechanics make it difficult for them to maintain an end expiratory lung volume above their functional residual capacity. And so sometimes they'll need additional pressure to help keep their lungs at a higher level. There have also been some mentions in the literature specific to spinal muscular atrophy and some other early onset neuromuscular conditions that using non-invasive ventilation can help prevent the development of thoracic deformity. So how do we assess the need? Arguably, the gold standard and the preferred approach is to do a full 16-channel polysomnogram. And that includes a series of electroencephalogram or EEG leads to assess sleep stage. And that's important because in deep sleep and REM sleep, that's the most common time to see respiratory events, whether that would be obstruction or underventilation, hypoventilation. In addition, we need measures of gas exchange for both carbon dioxide and oxygen. For carbon dioxide, we can use end-tidal carbon dioxide levels, or we can do a transcutaneous across the skin measurement to measure carbon dioxide. In addition, we need to have a pulse oximeter on a finger or an extremity to be able to measure the trend of oxygenation in the blood. In addition, we need to measure flow through the nose. So there's a thermistor to measure nasal airflow to determine if and when that flow either decreases or stops. We need to also measure vital signs such as respiratory rate and heart rate, and then a measure of thoraco-abdominal motion. And this involves having a band placed around the chest and around the abdomen. And then we'll be able to measure how synchronous breathing is. Now, Dr. Ghazal, who's a world expert in obstructive sleep apnea and sleep medicine, will be going into more detail on how to use this type of technology to assess and manage obstructive sleep apnea. I'm going to spend the rest of my talk talking about using this in relation to respiratory insufficiency and ventilatory support. So the data that one gets from a sleep study includes the presence of apnea, whether that be central, meaning a decreased drive to breathe, causing no airflow, or obstructive apnea, where you have an attempt to breathe, but the upper airway is obstructed and no air is able to get in. There also is another type of breathing abnormality called hypopnea, which is by definition a 50% reduction in nasal airflow that goes along with a 3 percentage point decrease in pulse oximetry, and then asynchronous breathing. If there's no effort to breathe or a decreased effort, that would be a central hypopnea. If there's an attempt to breathe and there's an hypopnea, we call that an obstructive hypopnea. Now, parenthetically, that's something that can be seen when a patient with neuromuscular disease goes into REM sleep and breathes more shallowly. And that creates one of the confusions in interpreting sleep studies, that decreased respiratory effort in REM sleep in somebody with neuromuscular disease can be mistakenly interpreted as an obstructive hypopnea, where what it really represents in patients with neuromuscular disease is a decreased depth of breathing during deep sleep because of respiratory muscle weakness. And I'll get back to that in a little bit later in the presentation. In addition, we have measurements of oxygenation and carbon dioxide. And then, as I mentioned, the EEG leads give you a way of determining whether a patient is in deep REM sleep, where most of the respiratory events will occur, or non-REM sleep. So then the two general categories of diagnoses are obstructive sleep apnea. And with that, we can determine the presence of both apneas and hypopneas, and then the trend of oximetry through the night. Respiratory failure or hypoventilation requires an end-tidal CO2 tracing, in addition to a transcutaneous CO2 tracing, and sometimes a pulse oximetry assessment. Now, the preferred approach would be to diagnose hypoventilation during a full 16-channel sleep study, but it can also be assessed just by having a continuous recording of CO2 in a controlled environment to ensure the quality of the tracing. Now, that typically requires an inpatient stay in the hospital, though there's some people that have shown that using transcutaneous CO2 monitoring can effectively be done at home. And in fact, that's the typical approach that my adult pulmonary colleagues take in managing their patients with neuromuscular disease. So how do we evaluate for ventilation or underventilation, hypoventilation? The preferred approach, as I mentioned, is doing a sleep study with an end-tidal CO2 or transcutaneous CO2 tracing. The current definition for hypoventilation or underventilation is a carbon dioxide value of over 50 millimeters of mercury for greater than 20% of sleep time. So that's the definition of hypoventilation for in the adult literature that has been inherited and used in the pediatric literature. And in patients with progressive neuromuscular disease, nighttime hypoventilation occurs before daytime hypoventilation. And for that reason, we focus on sending patients to the sleep lab to be able to identify the earliest stage of hypoventilation or respiratory failure. When it occurs first in REM sleep, because that's the stage of sleep where all of the muscles relax and whatever compensation the patient may have available to them during the day goes away completely. So while the preferred approach is to do a full 16-channel polysomnogram, as I mentioned a minute ago, we can also get a pretty good assessment of ventilation by doing a transcutaneous or end-tidal CO2 tracing continuously in a controlled environment. So I want to go through some of the data that we get from a sleep study. And this is a tracing from one of our sleep studies in our sleep lab. The top graph has a rating of what stage of sleep the patient's in. And the thick bars on the top tracing represent when the patient is in REM sleep, which is where they're in deep sleep and their breathing muscles are fairly relaxed. And because of that, they are at risk of respiratory difficulty. If you go down to the thick bar, which represents the capnography tracing, I drew a line, a red line at 50 millimeters of mercury. So whenever you see black above that, the patient is underventilating based on current guidelines. And so you can see that there are a few stretches through the night, many of which occurred during REM sleep where the patient was hypoventilating. So then what our sleep colleagues will do is they will look at these recordings and then print up a table similar to this with data, both gas exchange, which is up at the top, the CO2 tracing, the oxygenation, which is a little bit further down, and then the number of respiratory events, both apneas and hypopneas. So if we start at the top, the end-tidal CO2 tracing was above 50 for 17.2% of the night. That is below the critical threshold of 20 millimeters of mercury. So this, by strict criteria, would not satisfy the diagnosis of hypoventilation or respiratory failure. Now, interestingly, some people will say, well, boy, you can use oxygenation. And if the patient's oxygen level is normal, then everything is fine. And if you look down here, you'll notice that the number of times the patient, the percent of time the patient was hypoxic or hypoxemic was very, very small. Only 0.1% of sleep was the patient's oxygen level below 90%, while 17% of the time the patient's CO2 level was quite high at over 50 millimeters of mercury. So one of the things that is a current question and a concern of ours in neuromuscular disease in pediatrics is CO2 over 50 for under 20% of sleep, in fact, normal? And one of the other challenges that we face is that we routinely cancel patients coming for a sleep study when they're not well, because we want to get data that represents their well state. So one of the concerns is that we can be falsely reassured in getting a normal sleep study when a patient's well, that wellness, that ability to ventilate will carry over through and during an acute illness. And for that reason, we've assembled a group that is reviewing and will soon be publishing new recommendations for how to evaluate gas exchange, specifically capnography, in patients with neuromuscular disease. So once you identify that something's wrong, then what are the options? Well, at least for obstructive sleep apnea, continuous positive airway pressure is the preferred initial approach. And as I mentioned, in some patients where there's a need or an interest in increasing end expiratory lung volume or resting lung volume, functional residual capacity, you can also use continuous positive airway pressure. But for patients that require ventilatory support, which includes the vast majority of patients with neuromuscular disease, then we need ventilation or bilevel positive airway pressure. In addition, if you have somebody that has nocturnal hypoventilation and then they begin to hypoventilate during the day as defined by a high or by the presence of hypercapnia on an end tidal CO2 recording during the day, then we have the ability to support their ventilation using what we call mouthpiece ventilation, which, as the name implies, is ventilation through the mouth during the day using a ventilator that's affixed to their wheelchair or is positioned on a platform near them. And I'll show you examples of these a little bit later in the presentation. So how to initiate non-invasive ventilation? There are two main components. The first is the interface. How does the air get into the patient? The most common approach is doing a nasal interface, either a cannula or a mask going over the nose. Some patients do better with an oronasal or around the nose and mouth. And then in addition, we have a variety of different ventilators that now are quite sensitive and able to synchronize very nicely with patient effort. The next part is titrating the effect of the ventilation. And that's ideally done with the equipment that the patient will be using at home, though it can be done on lab-based equipment in a sleep study and then transferred to the patient's equipment. There are a number of different approaches. One is certainly doing a sleep study. The other is to adjust based on the patient's physiology, trying to decrease the amount of thoracoabdominal asynchrony. And then clinically also looking at their gas exchange, looking at their capnography tracing during the night. And if you adjust the pressures on ventilation to make the CO2 and the oxygen normal through the night, then you've done your job and you can be satisfied with the result. Though the most common approach, and certainly the standard, is doing a sleep study. Though the other two approaches can be used when there isn't a readily available sleep lab. So I want to move on to talking about the two components of ventilation. So interfaces. This is an old slide, but it still rings true in terms of different strategies for ventilating. So the top three devices are different forms of silicone-based interfaces. So the part that contacts the patient's nose is silicone-based, and there's usually an air bladder that fills with air when the ventilator is turned on, and that creates an air cushion between the mask and the patient's nose that provides some cushioning. Oftentimes, there is a forehead device that will help to distribute the pressure of the mask on the patient between the nasal bridge and the forehead, That's important because if you pull the straps quite tightly over the nose, patients can in time get pressure sores over the nose, which can make using the nasal mask very difficult. The devices in the bottom row on the left and in the center are interfaces that have a gel in the interface, and that can be, for some patients, quite comfortable. It also can mold to slight asymmetry in the nose and then the philtrum, and can also be warmed a bit to readjust to facial asymmetry. One of the things that we now have are masks that are specifically made for pediatric use, now that there are non-invasive ventilators that are able or approved by regulatory agencies to use in pediatrics. And this is one of those nasal masks. So this mask, as you might gather from the headgear and the tubing cover having a giraffe appearance, is clearly designed for the pediatric market. And so thankfully, there are a number of other devices that can be used. And this is good because before we used to have to use in an off-label way adult masks that were on the small side and never quite worked perfectly for pediatric use. Another strategy is using what we call a cannula interface, which, as you can see, fits on the nose, actually a combination of over the nose and then actually in the nose. This is nice for some patients because it decreases any obstruction to view through the eyes, and can be slightly more form-fitting. In general, cannula interfaces often don't work quite as well in supporting ventilation, but if adjusted properly, can be a reasonable way of alternating between a cannula, an interface over the nose and then a cannula interface. So it's a good second option in my view, but I think most people feel better supported using a mask over the nose. Here are two options for doing oronasal support. The one on the left is over just the mouth and nose. The mask on the right is over, as you can see, the entire face. And actually, this type of mask is often, at least in my institution, used in some of our younger infant patients. It seems to be fairly well tolerated. Sometimes we have patients that when they go to sleep at night, their jaw muscle tone decreases and their mouth opens. And certainly if you're trying to ventilate a patient by blowing air through their nose and their mouth is open, their ventilatory support is not going to be as efficient as it should. And in that situation, we can use devices to help keep the jaw closed. And there's an integral device for doing that in the interface over on the left. And then we can also just use literally a chin strap that we can strap or connect to the headgear, as evidenced over on the right, to keep the jaw closed. Here is an example of mouthpiece ventilation. In this current setup, this patient with neuromuscular disease has a ventilator mounted to the back of their wheelchair. And then the circuit, excuse me, is fed through an articulating arm that can have, in which the mouthpiece can be positioned right by the patient's mouth. So all they need to do is slightly tip their head to the side and wrap their lips around the mouthpiece and then initiate a breathing maneuver to get ventilation. For patients that have upper extremity function, they don't need this type of circuit, and they can instead have a flexible tube circuit that they can keep on their lap, and then when they need to take a breath, they can raise it to their mouth and start breathing. And this is that same device, a more modern version, through a ventilator called the Trilogy. And this circuit can actually be removed from a wheelchair and attached to a desk, a table, or anything nearby the patient when they're sitting and being and using ventilation. So for ventilation, there are two general categories. There are ventilators that are made just for nighttime use. And this is important because in addition to the fact that they're less expensive, they're less expensive because they have pumps and circuitry that aren't made for continuous use. So you cannot use one of these two ventilators, which are perfectly good ventilation for nighttime use. You can't use them full-time during the day. And a number of years ago, when we were beginning to do more non-invasive ventilation, when we'd have a patient that was on a non-invasive nighttime ventilator, they would need a backup ventilator to switch during the day to use during the day, so that the ventilator didn't get to the point of burning out and becoming dysfunctional. For continuous use, whether that's by invasive ventilation or non-invasive ventilation, excuse me, and these two devices are, at least in my practice, the most commonly used. And both are equivalent. They both have very modern algorithms for supporting ventilation in patients, both small and large, and are quite reliable. And again, they can be used continuously. And so this allows you to use provide ventilation both at night and during the day using the same ventilator. So let's talk about modes of ventilation. So as I mentioned before, for for obstructive sleep apnea, we use continuous positive airway pressure. And in the vast majority of patients with neuromuscular disease, that's not really a type of support that's needed unless there's clear evidence of obstructive sleep apnea with normal ventilation. And occasionally you'll see that. And in fact, I just saw that in two of my patients with Duchenne muscular dystrophy, where they actually, it's not uncommon in patients with muscular dystrophy who've been on chronic corticosteroid therapy to prevent progression of their muscle disease, that they may in fact have some form of obesity, and as a result can have obstructive sleep apnea. But when we do use CPAP in that situation, I tell the family that's just temporary, and eventually, as the patient's condition progresses, they will require ventilatory support. And that requires bilevel positive airway pressure. And so that also can be used in patients that have severe enough obstructive sleep apnea to where they're not responding effectively to CPAP and need inspiratory pressures that are into the 10, 12, or 14 centimeter of water range, which can be difficult for the patient to tolerate if done continuously by CPAP. So BiPAP obviously is for ventilation also, and that's really the primary mode of using it. And then for patients that require ventilation during the day, there's a separate mode called mouthpiece ventilation, in which an inspiratory pressure or a volume is delivered based on the patient's needs, but there's no expiratory pressure, no PEEP or CPAP after the breath. And that's to that's to prevent air coming through the circuitry when the patient's not needing the ventilator and has it out of his or her mouth. So for bilevel positive airway pressure, there are a number of different strategies. For patients that have a normal drive to breathe, we can use what we call spontaneous mode, which is where a pressure is delivered when a patient triggers the breath. And the triggering both is to turn the breath on. And so what happens is the patient breathes, the ventilator perceives an increase in flow through the circuitry, and then recognizes that means that the patient is beginning to take a deep breath. And so the breath will be delivered. And then when the patient stops breathing, there'll be a change in flow. And then with that, the ventilator should trigger the breath off. Now, one of the problems sometimes is in a particularly weak patient, they may not be able to exhale forcefully enough to turn off the breath. Or if there's a mouth leak or a leak in the circuit, then the ventilator may not sense when a patient's trying to breathe out. And sometimes they can have a particularly long breath that's not comfortable and not physiologic. I'll get back to that in under pressure control. Spontaneous timed mode is spontaneous mode, so patient triggered breaths with a backup rate, excuse me, that mandates a certain number of breaths. So if you want a patient to have a normal physiologic number of breaths at a bare minimum, say 16 for an older child, you can set that rate. The patient can then get whatever number of breaths they need above that. And as I mentioned, the termination of the breath is based on change in flow. And pressure control is similar to spontaneous timed mode in that there's a backup rate. The patient can also breathe above that, but as a backup to the flow termination, you can set an inspiratory time and say, I want this breath to be delivered for 1 second, 3/4 of a second, 1.2 seconds. And when the breath has been delivered for that amount of time, then it will terminate. And the advantage of this support is that this gets away from having say this is an optimal way of breathing for a patient that is having challenges in effectively terminating the breath. And that often is used in our patients with neuromuscular disease. So there are a number of different algorithms that companies have developed to help improve patient ventilator synchrony. Philips Respironics, which makes the Trilogy, has a setting called AutoTrack. And what this does is it's an algorithm that predicts the timing of a breath based on the patient's previous breaths. Excuse me. And so what that will do is the ventilator may perceive that there's a breath every 3 seconds. And so it will set a target time of 3 seconds from a previous breath for that next breath to be delivered. And if it's longer than that, then it will go ahead and deliver the breath. ResMed, which produces the Astral, another very common ventilator used, has an algorithm called IVAPS. And that's an algorithm that adjusts the inspiratory pressure within a set range to ensure that a patient's getting an adequate tidal volume, okay? And so if the patient changes in some way, positioning, if the patient's chest compliance or respiratory compliance changes, and a higher pressure is needed to give the same volume for to maintain minute ventilation, then that patient will get a higher pressure. So these different settings are used as part of the initiation process and certainly can be used to improve patient tolerance and follow-up from initial titration. So for mouthpiece ventilation during the day, what you do is you have a mouthpiece that's set on the patient's lap or near their mouth, and then you either set a volume or a pressure, and you titrate the volume or the pressure based on patient comfort, excuse me, and also make sure that the patient's gas exchange ventilation is adequate. Now, as I mentioned before, there is no expiratory pressure when you're doing mouthpiece ventilation because when you're not using it, the circuit is left open. And if you had a pressure through the circuitry during that time, you'd have continuous flow and there would always be air coming out of the circuit. So to get around that, the only pressure that goes, or the only air that's going to the ventilator circuit is when the patient's trying to take a breath. So there are a number of I want to finish off with talking about some of the challenges that we face in successfully managing non-invasive ventilation. The most common by far is poor patient ventilator synchrony. And what that can do is that can mean that when a patient's trying to breathe, it's not getting a breath, the patient's not getting a breath from the ventilator, or when the patient's trying to breathe out, even more importantly, the ventilator's trying to breathe in, or it isn't releasing the breath. And one of the most common causes of that is a mouth leak. And so I showed you a picture earlier of strategies for dealing with a mouth leak, such as having a strap around the patient's jaw, or even switching to an oral nasal mask. And in some situations during an acute illness, when you have somebody that has been on non-invasive ventilation, if there's a need for perfect patient ventilator synchrony, and in particular using higher pressures, then sometimes we'll shift to using an oronasal mask. And that can be the difference between successful ventilation or not successful non-invasive ventilation and needing to move towards invasive ventilation. In addition, sometimes we can adjust the sensitivity of the trigger to turn on a breath or turn off a breath. In addition, we can sometimes do what we call capture a patient's breathing by predicting what type of a respiratory rate they're using, and then set the ventilator to deliver that number of breaths. And oftentimes, as a patient goes into deeper sleep, they'll settle into breathing comfortably with the ventilator more in control mode, where the breaths are being given at a set frequency. In addition, breaths such as using a pressure control, where you can more thoroughly adjust the way that the breath is delivered, and in particular with a time termination, that can prevent patients from having breaths that last much longer than what they're comfortable with. And then looking at the ventilator, obviously we want to make sure that there isn't a leak, and that's can be a very common cause of poor patient ventilator synchrony, especially in our younger patients. So you want to check the circuit and make sure, check the mask and make sure that there's no leak around the mask. You want to check the circuit and make sure that there's no disconnection or no faulty connection. And then sometimes, as I mentioned, we can adjust the rate to better approximate what the patient's needing. And then sometimes the patient needs or is demanding breaths coming in at a higher flow or a higher level. And so sometimes adjusting the peak pressure, increasing that can be very helpful. In addition, having objective data such as carbon dioxide or supplemental oxygen, or oxygenation can also be quite helpful in ensuring that you're properly supporting the patient. So in conclusion, non-invasive ventilation can be done very well and is a viable option for providing respiratory support for pediatric patients of all ages. It just requires putting focused time into ensuring that you set things up properly for each individual patient. Successful initiation of non-invasive ventilation requires both a broad assessment with testing, and then initiating in an organized manner, and then also more longitudinal support of the patient based on what his or her needs are. And so with that, I will conclude, and I will stop sharing my screen and then be willing to entertain any questions that there might be.
Thank you so much, Professor Meyer, for a very informative presentation. There are a few questions on our Q&A area here, and I have a few questions as well.
Okay.
First question from Samia is, in patients with hypotonia, for example, Down syndrome, what is the acceptable SpO2 during deep sleep?
That's a very good question. I mean, the typical thought would be somewhere between 90 and 95%. Once you drop below 90%, of course, you're at risk of fairly significant hypoxemia. That's getting below the on the oxyhemoglobin dissociation curve. That's getting to the steep portion. Yeah. So we like to stay above 90. Some of that is based on tolerance, and Down syndrome in particular, I've found to be very difficult to support because of facial aversion and challenges in maintaining something on the face. So I would say at the very least over 90.
Over 90 at least, okay. Zainab is asking, I want to ask about ABG before and after sleep study. Is it important or not?
For measurement of CO2, well, if talking about a sleep study that has capnography, then I don't see that an ABG would be necessary. Having said that, if you're not doing a sleep study, doing an ABG before sleep and then after awakening can be very useful. We tend to use a lot of transcutaneous CO2 monitors in our hospital to be able to monitor continuously through sleep. And that to me would be the ideal approach.
Okay. I have a question here from Jose, who's asking, what can you recommend to reduce or even eliminate the incidence of pressure sores caused by nasal facial interfaces, especially for neonates or pediatric patients?
Thank you for that question. That's an exceptionally important question, and it's very difficult. The honest answer is trying to use just the bare minimum amount of pressure possible on the nasal interface to keep it sealed. And what I usually instruct parents on doing is when they put the mask on, increase the tension in the straps for the headgear until you have no leak around the mask. And then start to relax it a little bit until the leak comes back, and then tighten it just a small amount. And that can often work. We have we use a Duoderm, which is a gel padding that's about 2 millimeters, 1 to 2 millimeters thick. Often we'll cut a amount that goes around the nose perfectly underneath the mask to provide a cushion. We've had parents that have used cosmetic pads, especially over the forehead. And I actually have found parents, based on just simple survival, finding wonderful creative ways of placing the mask on their patient, and I'm sorry, on their child, in a way that's comfortable for them. In extreme situation, there are kits to be able to make a custom mask, and we often can engage with our dental mouthpiece colleagues to help with that. Thankfully, there are more nasal masks available, and we haven't really had to do that very much.
Majid has a question. At which SpO2 level will you be comfortable to rule out the likelihood of hypoventilation when CO2 monitoring is not used?
That's a tough question. And so I mentioned very briefly that we're creating a document that hopefully will be out by the summer with some new guidelines for monitoring ventilation and oxygenation at night. And the general consensus was that if the mean SpO2 at night, again, this is just in a patient with where you're worried about hypoventilation. If the mean SpO2 is below 94, then that was a concern. Now, of course, the preference would be to have a capnography tracing. But to answer the question, I would say if you're 95 or above, the likelihood of having hypoventilation would be exceptionally low.
Okay, great. Dr. Ayman has a question. What would be the most optimal SpO2 with a patient with micrognathia?
I would still look at, I would want to see an SpO2 somewhere in the mid-90s, 94, 95.
I see. And Nisreen, I think it's Nazreen, has a question, how to manage oral secretions with NIV?
Very good question. Oftentimes, patients, when they have non-invasive ventilation and have air blowing through their nasopharynx and oropharynx, they may not swallow as much as normal. And so outside of the obvious suctioning, which isn't convenient to use at night, perhaps using an anticholinergic like glycopyrrolate could be helpful. Though that's, of course, with the concern that without a proper dose, you can over dry the saliva and make it thick and hard to clear for a patient. But this is a very difficult question. I would also just, as a separate query, wanted to make sure that the patient wasn't having gastroesophageal reflux, which obviously is quite common when lying down at night. And just that act of reflux could cause you to hypersalivate. So
Yeah.
that would be one additional thing to consider.
The literature is very, very intense on the issue of GERD, especially in pediatric patients. What is your recommendation to manage patients that have GERD who require a non-invasive mechanical ventilation, given the increased chance of regurgitation and a risk of aspiration?
That's a very good question. One of my former critical care colleagues said that the pressure to open the lower esophageal sphincter was, I believe, 16 to 18 centimeters of water. And so that was something that he said in response to concern about non-invasive ventilation causing vomiting or causing gastric distension. So certainly in somebody that has requires pressures significantly above that, you could certainly make GERD worse. Having said that, I haven't found a whole lot of difficulty in the patients that we follow, though because of the risk of aspiration, I have a very low threshold. In spite of what my GI colleagues would prefer in using an antacid to try and minimize the chance for at least acidic reflux. And I've had experience in some of my patients with spinal muscular atrophy, where before they have an adequate way of providing post-pyloric feedings, they have small volume reflux and aspiration. And so I've become very aggressive, especially in my young infant patients with neuromuscular disease, and empirically treating reflux, even without the assistance or even support of my gastroenterology colleagues.
Okay. Basil has a question. He's stating that polysomnography is the gold standard, but very resource intense. What is your take on CRPG, cardiorespiratory polygraphy, and concordance with polysomnography in view of supporting NIV?
Yeah, so if we're doing NIV for general respiratory events, meaning obstructive sleep apnea, then a pneumogram or a more simpler study could be perfectly fine. If we're concerned about hypoventilation, then you can get by doing just simple capnography at night. The challenge, of course, is not knowing the variation in ventilation based on sleep stage. So even without that, I think you can just with a CO2 tracing get exactly what you need. I don't know if that answers the question effectively or not.
Well, I think you need somebody who's done CRPGs to be able to really give you their take on it, because it's not that easy, and it's very complicated to put together and then evaluate. What are your predictors for success, and what are your predictors for failure in patients whom you put on NIV?
So I'll answer that more from the perspective of neuromuscular disease, because that's what I typically manage. And there are kind of two things. One, there's an initial shock and concern, because this is a threshold, at least in development or progression of neuromuscular disease, where you have respiratory failure. Once we get through that and start talking about how to move forward, there's typically quite good buy-in, at least from the parents. Now, the patients are another issue. And depending on the cognitive ability of the patient or their sophistication, meaning a teenager versus a preschooler, you may be able to talk them through in a rational way why we need to do this. And more importantly, on the other side, say, well, hey, you're waking up, you have a headache in the morning, you're having trouble focusing, this is going to help you do better. And when I do an initiation of ventilation, which I've done at least before the COVID pandemic in the hospital, when I set things up at night, I will tell the patient when I come back in the morning, I'm going to ask you how you feel. And in almost every situation, they say, wow, I feel great. I've slept wonderfully. And it's because they finally are able to sleep quietly and restfully without having arousals or awakening because of gas exchange abnormalities. And once we get that, we can fall back on that and say, look, you're going to feel much better if you use this. And at least in somebody that has the sophistication to have that type of a discussion, that can work quite well. Parents typically, once for the younger patients, I don't typically have much difficulty getting them to buy into using ventilation. And then they usually find that in time, with persistence, their child will eventually recognize that it, while is not particularly comfortable, it is something that's important. And I wouldn't say we have 100% success, but usually with just persistence, we've been able to work through almost every case.
But the change in polysomnography, data that you find with CPAP or BiPAP is an objective assessment of success of the
absolutely.
of the treatment.
Yeah,
when
we will.
Go ahead. Sorry, go ahead.
Yeah, we will sometimes do that in follow-up, especially if we have a patient where they're just not quite feeling like they're getting much benefit.
Yeah.
But if a patient says, "Oh my gosh, I feel wonderful. This is I have so much more energy," then there's no need for that objective data.
And what's your preference for ATCO2 versus TCO2? Which one do you use more, the end-tidal or the transcutaneous?
Well, it depends on the situation. Well, for outside of the sleep lab, transcutaneous CO2. Because an end-tidal CO2 tracing can become unreliable unless it's continuously maintained. And that can be done in a sleep lab where you have a therapist that can go in and continue to move it around the nose properly. The newer transcutaneous CO2 monitors don't cause as much skin difficulty as the old ones did, where you had to shift from one spot to another. So there's also quite a bit of developing information about using transcutaneous CO2 monitors at home. And in fact, my adult colleagues do that quite reliably in their adult patients to prevent them from having to come in for a sleep study or just to make sure that their ventilation is still set properly for them.
Mizhar has a question. After what age we can use an IV?
Well, that's a good question. In theory, it should be at any age, but the older you are, I would say once you get up towards 7 or 8 months of age, you should be able to find a reasonable interface to be able to use at home. That's the first part. The next part is, of course, adjusting the sensitivity of ventilation to make sure that it works well for the patient. So I would give it a try in anybody. But I would feel much more confident in somebody that was maybe 8 to 12 months of age and having it work perfectly at home.
And Khulud has a question, but I just want to jump in. When you mentioned doing sleep study, you said that it depends on the illnesses or how well the baby is to be able to do. What are the illnesses that would preclude you from doing a sleep study for a child? A fever?
Sure. Yeah, very good question. So because the typical approach in doing a sleep study is to look at upper airway obstruction, at least pediatric sleep studies. If you have somebody that has rhinitis, has congestion, you don't want them to have a sleep study to look for obstructive sleep apnea because they may have some amount of obstruction just because of the upper airway congestion because of an acute illness. Now, having said that, in my neuromuscular patients, if they have a normal sleep study when they're well, that does not in any way mean that they'll continue to have a normal sleep study, normal ventilation when they're sick. And so in the document that we're going to put out, we're going to propose some capnography and other sleep study criteria that may foreshadow difficulty during an acute illness. So sort of, for lack of a better term, borderline hypoventilation. So that if you fall into that category, you need to be aware that, boy, if my son or daughter gets sick, the doctors need to know that they may need to be on a ventilator.
Khulud has a
Or
question.
yeah.
She has a question. She says, do you suggest helmet for COVID-19 patients for NIV?
No. So if you're talking about at home use, no. In the hospital, when I would see a patient in our outpatient office who requires ventilation, be it non-invasive or invasive, we would use stricter protocols for isolation. We would have an N95 mask on, and then eye protection, in addition to the standard droplet precautions. In the hospital, we have enough rooms, patient rooms, that are negative pressure, so that we can turn that on when a patient's on non-invasive ventilation. But we haven't done anything beyond that to, put a helmet or a drape over a patient when they're on non-invasive ventilation.
There's a question here. What is the acceptable SpO2 for cardiac cases? And I'm not sure what Galaxy means by cardiac cases.
Yeah, I think that has to depend on what the particular situation is. As an example, if you have somebody that has pulmonary hypertension, that threshold might be exceptionally high. But certainly for somebody that has a AV malformation in some way, intracardiac or extracardiac, obviously that'll depend on what the cardiologists say is an acceptable range. And so I typically, when asked that question, will go refer to the most recent cardiology report.
Brahim says a question. Can we say everyone snoring needs a sleep study?
Well, it depends on who you ask. So when I have a patient in my office and the parents say my son snores or my daughter snores, if it's a young patient, I say that pretty much everybody that your child's age that has obstructive sleep apnea will snore. But on the other side, not everybody that snores has obstructive sleep apnea. And so if you want to be, catch absolutely every patient, then yes, the answer is if you snore, you need a sleep study. But I like to think that we can tease out the history a little bit and ask some questions and get a sense of whether this patient really is likely to have obstructive sleep apnea. That's with the acknowledgement that that's never going to be perfect. But if the parents say, well, boy, the last few months my son has been snoring and the behavior during the day is absolutely terrible and he's napping more during the day, then that to me would suggest that the patient probably has a high risk of having obstructive sleep apnea and probably should go ahead and get a sleep study.
What is your cutoff to switch patients from CPAP to BiPAP?
When they start, well, for obstructive sleep apnea, is when I was doing that type of management, when they required a CPAP of above 10 centimeters of water, I would switch over to bilevel pressure. I've had some sleep colleagues that think that have felt otherwise, that they just go up on CPAP to 10, 12, 14, whatever is needed, and insist that it is it's tolerated. And the argument that I've heard for that is that you need that high pressure both to support patent airway on inspiration, but also on exhalation to prevent, I believe, uvular sort of trauma and sort of flopping back and forth. Though in my practice, in my world, I set a threshold of 10.
10. One final question. In your practice, how often do you see the more rare neuromuscular diseases like Warding-Hoffmann syndrome or Schwartz-Jampel syndrome? Are they prevalent in the US or rare?
What was the second one?
Schwartz-Jampel syndrome and Warding-Hoffmann syndrome.
Yeah, Warding-Hoffmann we see quite commonly. I'm not familiar with the
Schwartz-Jampel.
Yeah, I've not.
It's a neuromuscular and also bone disease, but it causes it's like ankylosing spondylitis where you have stiffness of the chest wall, and these patients don't breathe very well.
We see a lot of we see a lot of very rare neuromuscular conditions because we're sort of a regional center for referrals. And I have a collaborative relationship with some colleagues at the National Institutes of Health who manage patients with rare neuromuscular conditions. And so we see probably a pretty broad array of rare conditions. From my standpoint, the diagnosis is less important, really important in terms of prognosis, but the management, both initiating ventilation and in a completely separate topic, airway clearance support, to me is based on the patient and not so much the diagnosis.
Great. We took too much of your time. Thank you so much. It was very informative, very interesting. And we look forward for the next lecture.
Okay.
Sometime in the next couple of days. Thank you so much for your time.
Thank you.
Have a very, very pleasant day.
For the privilege of speaking.
Thank you. Thank you to all the attendees. Have a very wonderful time wherever you are. In Riyadh, we are in the evening. It's almost 8:30. And we'll see you tomorrow morning, inshallah, for the or tomorrow afternoon in Riyadh time for the main conference. Thank you and have a very pleasant day.